Good morning, everyone, and welcome to the 37th annual Nesbit meeting here in Ann Arbor. It's really a pleasure to see everyone this morning. We really are grateful for everyone who made a long trip from some folks from extraordinarily far away, both overseas as well as around the country, to spend their days, next few days here with us here at our Nesbit meeting. Before we get started, I wanted to just say a couple of things. First is a note of thanks to a number of people who have really made this meeting happen. A lot of blood, sweat, and yes, sometimes tears to organize the meetings of this scale. Brittany Smith, Tammy Leckenby, Ruth Kirk, Natalie Brown, Sandy Heskett, and certainly I think who all deserve a round of applause. And I would say one extraordinary individual, Dr. Go. So this is no small feat, as you might imagine, and Mady does not get paid to do this. She does this out of the kindness of her heart and her extraordinarily strong passion for our department in the Nesbit Society. So, Mady, I'm extraordinarily grateful. This event is only because of you. Thank you. Both this event here and at the AUA. Thank you. Okay, so we've got a great program for you tonight, today, and tonight, I hope. Anyway, today, amazing speakers. Encourage you all to take notes, ask questions, and perhaps as importantly, during the in-between moments, during the breaks, take a moment to introduce yourself to someone you do not know. Again, the real beauty of the meeting of something like this is where we get to intermingle generations of Nesbit alumni, both present and past, and maybe even future. Meet our visiting speakers, share some knowledge, and catch up with old friends. I mean, that's really as important as the educational program here today. I'd also like to take a moment to thank our corporate sponsors. This year we've had three extraordinarily generous sponsors, Urogen Pharma, Boston Scientific, and our own Linux DX. So let's give them all a hand. All right, well, with that, I'm going to turn it over to Dr. Go, Mady.
All right, thank you. All right, thank you, everybody. Good morning, welcome back. I'm just gonna do some housekeeping things. When you walked in, you've got a program. Eventually, you're gonna need these after lunch. There's gonna be a session on ergonomics in the OR, and this is laminated so you can take it home with you and use it in your OR. We're gonna do pictures at 11:30. We're gonna go upstairs near the main entrance. We're gonna go through a set of stairs to the right of the entrance. If you're facing the building, we'll direct you guys there. And then tailgate tomorrow is at 309 Berkeley. Remember, load your tickets before you get to the site. If you try to do it, the Wi-Fi is terrible there. You're going to be frustrated. So please don't do that. And now, without further ado, if I can see where he is, our very own PP doctor will start the series. Welcome, Dr. Khurshid Ghani.
Thank you, Dr. Go. Where's Dr. Palapattu? Thank you, Dr. Palapattu. Where's Dr. Wei? John here. Dr. Wei, thank you. Thank you for giving me the invitation to speak at the meeting. Dr. Go is actually, I've been calling her mum for the last couple of weeks, as Dr. Palapattu has been mentioning, taking care of everybody, taking care of this meeting. So I think before I begin, let's just give Mady another round of applause. Russell, video team, could you put the clock back at 20 minutes? I need every second, okay? And then, I've started a little bit earlier than on program, so I got a little leeway. Okay, so I'm gonna speak to you today about management of upper tract urothelial carcinoma with the thulium fiber laser and the use of an agent called UGN-101, otherwise known as Jelmyto. I don't see the slides up yet. Mike, yep. Oh, I had to press this button. Good morning, Nesbit family. I have to give a lot of credit to these slides today to Dr. Galina Fernandez. Galina's at the back there, who's one of our research fellow. So let's talk about this and what have we been doing here at Michigan Medicine with respect to this disease and its management. My disclosures are noted here. I am on the advisory board of Urogen. Urogen is the company that makes this drug called Jelmyto, and we are about to sign a research grant with Urogen as I'm the PI for a multi-center registry of urogen and upper tract urothelial carcinoma in the United States. So those are the two relevant disclosures. Urogen is a sponsor of this meeting. Urogen doesn't even know what I'm speaking about. So I do, Ganesh, I think. We can wing it. Why does this matter? Why are we here? Let me tell you about this 69-year-old male patient of Dr. Weiser's who presented with gross hematuria. CT urogram, 2.5 centimeter mass in the right lower pole, biopsy done showing low-grade urothelial carcinoma. 2.5 centimeter mass in the right lower pole. And if you look at the EAU guidelines, it would recommend that nephroureterectomy is the standard for masses. Even though if they're low grade, they're more than 2 centimeters in size, the standard of therapy is loss of kidney nephroureterectomy. Upper tract urothelial carcinoma in the United States, to get at a sense of incidence, it varies. American Cancer Society says 4,000 cases a year. SEER estimated incidence is around 7,000 cases a year. It's around 5 to 10% of all urothelial carcinoma. It's a rare disease, but it's still a disease that we see. And because of the recurrence and the surveillance, it's one that we see in great intensity, especially at units like this. And me as an endourologist, why does this matter? We heard from Dr. Nakata yesterday, 70%, 60% of all the surgeries that we do are endoscopic. We're all endourologists. And if you look at the recent SUO AUA guidelines, which just came out, which are a phenomenal document, which is referenced here, Jonathan Coleman, the first author, tumor ablation should be the initial management option for low-risk, favorable upper tract urothelial carcinoma. Tumor ablation may be the initial management option for low-risk, unfavorable urothelial tract carcinoma, and select patients with high-risk favorable disease who have low-volume tumors or cannot undergo radical nephroureterectomy. So today, for my talk, 5 learning objectives. I'm going to talk about how to do ureteroscopy and biopsy. I hope this can speak to many of the audience in the room, but many of us are in general practice. And I think this is an area that we really struggle. And I see that because I have a referral base where many of the patients are sent to me with no diagnosis. I'll touch briefly on risk stratification of disease. I'll talk to you about why we've transitioned to thulium fiber laser and the laser settings and technique. And then how we've been using this agent in the post-treatment phase called Jelmyto in the clinic for installations, and then some of our outcome data, both I'll touch upon the national data from the Olympus trial, but also some of our local data outcomes here at Michigan Medicine. So first of all, how to do ureteroscopy and biopsy, cytology. I do not do a retrograde as the first step of a suspected case of a filling defect or a mass in the upper urinary tract. I do not do retrograde, and I was taught this by my mentors in the United Kingdom. And now it's in the AUA guidelines. Adjunctive cytologic barbotage washing with saline obtained should be done prior to the use of any contrast to get the best cellular yield. Do you do barbotage or washing? I do both. I do as much as I can to get a diagnosis. And the AUA speaks about barbotage and washings and irrigation aspiration, passive collection. And again, they say you should do this before retrograde, again, to get the best yield. The world expert on upper tract urothelial carcinoma in this field is Marianne Bremer from Stockholm and Karolinska. And if there's one thing, if the practitioners out there, and you get this paper from Scandinavian Journal of Urology, how to do an accurate biopsy and cytology, and she writes about the tips and all the things. And I've modified my technique based on her lectures, and we hope to get her here to Michigan Medicine next year to speak to us about their experience in Karolinska treating this disease. But the issue with the biopsy is that if you look at the literature, around 50% of all biopsies are non-diagnostic. The samples are too small, they don't work. There's various devices you can use, but the most common used device is the Piranha from Boston Scientific. It's a 3 French device. Our working channels are 3.6 French. There's no irrigation. Vision is an issue. You can do baskets, but the major issue is small samples and vision. And Dr. Alex Zhu is in the audience, one of our chief residents, and we with engineering department over the last 1 year, we've been trying to develop a new biopsy device, and that's still a journey that we're undergoing. But for me, the main device that I've been using is the Boston Scientific Piranha. And so this is some videos just to show some of my technique. So the first thing is I will do, with the Piranha, when I put with the forceps onto the specimen and I'm pulling the tissue, I teach the residents, we pull really slowly. We want slowly so you can get the maximum tissue coverage and bite. The other tip, which I got from Serena Matin at MD, was the avulsion technique. So instead of pulling, you push, and so you push the tissue away, and then you get this big bite come through. And I liked yesterday your lecture, Dr. Nakata, where you showed the Uroseal, and you can see here I'm using the Uroseal as well, and we'll talk about that in just a moment. But one of the major things that you have when you do these biopsies and you have these devices is once you do the biopsy, you get bleeding. And so this is an example. You've just done the biopsy, and now you've got blood in the field. And so the next step I will do is we will remove the sample. We will So this is the beautiful thing about the Uroseal made by Sterad, that it comes out cleanly, and then once you lock it, you put the flow on, you clear your field. So this is the critical next step for us. So what we call lock and flush, where we clear the field so we're ready for the next biopsy. And then I think this is the most critical thing, and hopefully everyone is doing this, I'm not really sure, but I used to put the specimens onto Telfer classically, and I would say that we don't do that. What we try and do is we put it straight from the forceps into a sterile container, and then with a bit of saline in there, and then we'll move it around, and then the specimen drops into the pot. And I was told to do this by our pathologists here. They were like, we cannot get tissue samples from the Telfer. And I can see Todd and Alon sort of having a discussion, and I'm curious to know like what their techniques are now. So, and Marianne, if you look at the Stockholm technique, they actually put it in a small test tube pipette. They're even more pedantic, but we put it into the container directly. At the Guys, where I did a lot of my training on this subject, they would put the solution directly into Booins, with andrologists here, Booins, but we can't get Booins here, so I have to put it into formalin. Right, so the other interesting thing, and again, the AUA discusses this, and this is based a lot on Marianne's work, is that after you've done the biopsy, then do a cytology. So it's a post-biopsy cytologic wash or aspiration to, again, increase your cellular yield. Another interesting thing that we've been doing is using this device called the Cysto Assist. So this is developed by Will Johnston, one of our Nesbit alumni and Dr. Hollander knows him well, practicing in the Royal Oak group, and this is a device that's selling by Mediflex, and the open surgeons will know this, like it looks like an open surgeon type of retractor, and it holds the cystoscope, it can hold the access sheath. But one of the things, and this is a video from David Keynes who shared it with me, we have this at the VA, and now we're using this. It holds the ureteroscope. And so it now provides a degree of autonomy. So at the VA, we're doing the biopsy devices with the ureteroscope held, and now I have more surgeon control. And I do predict that the Cysto Assist in general in endoscopic surgery will become more and more popular for various reasons as our devices change. So that was how to do ureteroscopy and biopsy. And let me just talk to you about risk stratification. And this is all from the AUA guidelines. The AUA guidelines break down the risks into low risk, low grade. basically because it's sort of unifocal disease, low risk, unfavorable, and that's because it's multifocal in a simplistic format. And then there's high risk, high grade disease that's either favorable or unfavorable. I won't go into the details there, but that document goes through everything. And so when you diagnose a patient, you want to categorize them. It doesn't go too much into size categories like the EAU guidelines does in terms of, but in general, we consider 1.5 or centimeter or 2 centimeters greater as a higher risk side. So let's just talk about laser technique. We heard from Dr. Nakada yesterday, they did the 2 different types of lasers, thulium fiber laser or holmium laser. And which one do you use? For stone disease, I think the jury's still out. Dr. Nakada's randomized trial showed they were sort of equivalent. And so one would say for laser ablation, are they equivalent? There's very limited data looking at this in the laboratory. And they have different coagulation properties. You've got some HoLEP surgeons who do not like using the thulium for HoLEP. You have some HoLEP surgeons who love using the thulium for HoLEP and now transition to thulium called Thulep. But when you look at soft tissue for your upper tract urothelial carcinoma, very limited studies have been done. One study from Olivier Traxer's group in France showed that there was greater tissue penetration with holmium. With thulium fiber laser, another study showed that it cut better, it absorbed, the vaporization effect was better. And another study showed that there was more coagulation with thulium fiber laser. So limited data, but my clinical experience so far, and I'm curious to know what Todd thinks and others who've been also using this laser in their clinical practices, I've now transitioned to all laser ablations to thulium fiber laser. I've seen that it's much more hemostatic. So let's talk about laser ablation. I think the biggest thing when we're undertaking these journeys with patients is to set expectations, that this is not just one surgery and we'll get your cancer and it's done, that you might need a second look, that there's a recurrence. If you look at the literature, 50 to 70% of patients with upper tract urothelial carcinoma get recurrence. And so this is a journey, and so we really explain hard to set expectations around that. In terms of using the laser, the thulium fiber laser, when we're treating kidney tumor volume, so in my algorithm, if it's a small kidney tumor volume, I won't use a urethral access sheath. We had that discussion yesterday. I will use the smallest laser fiber that the thulium fiber can go down to, which is right now, you can get to 100, but right now 150 is what we use in the operating room here, and I use gravity-based irrigation. If it's a large volume tumor, you can see the algorithm here. I use an access sheath, higher flow irrigation, and a larger fiber. Should you use a urethral access sheath when treating upper tract urothelial carcinoma in the kidney? Some folks don't like it, some folks do. Interestingly, a paper from USC recently showed that if you used it, there was a lower rate of intravesical recurrence. It was a retrospective analysis. But if you do use an access sheath, you must visualize the entire ureter before you place that, and that's an AUA guideline statement. In my schema, I like to use it if it's a large volume tumor, but I prefer to use it at the second look where the patient's been pre-stented. Because the worst thing you want to do is use a urethral access sheath, have a urethral injury, and now you're concerned of a 1 centimeter tumor in the kidney that you treated really well with a possible urethral injury, right? That would be a concern. So I think there's some aspects around that. The thulium fiber laser, the 150 fiber, is very, very thin. And we started to use it and we got very frustrated because it would get stuck in the working channel. And, you know, that led to, and the residents know that leads to like endoscopic rage, right, in the operating room. So, and then I heard from Olivier Traxer, he said, well, I had the same problem, but what you want to do is you want to cut the fiber tip. Cut the fiber tip, cut off the transparent tip, it makes it softer, and now it will enter the working channel much more easily. So on the left, you see a laser fiber ablation of a 2.5 centimeter tumor in a horseshoe kidney that Dr. Salami and Dr. Samerjian sent to me. And you can see that initial single stage, that first stage, I'm using a 150 fiber, using gravity irrigation. My setting is 1 in 10. All you need to remember is 1 times 10. That's it. 1 in 10 is the setting with thulium fiber laser, and use the short pulse. And you can see that it fluffs the tumor, very little bleeding, and it's very hemostatic. You do need to sort of scrape off the tumor as you fluff it now and then. This is the same patient at the second stage, and now we have a urethral access sheath. I have a digital ureteroscope with better vision. I've got higher flow, and I've got a 200 fiber because the tip is not cut. Please do not cut the tip of a 200 fiber. If you do, it doesn't work very effectively. There's a lot of carbonization and charring and burn back. So now let's just move on to gel mito and this product called UGN-101. It was released in 2020. It's a mitomycin-containing reverse thermal gel, which transforms the chill liquid that then conforms to the collecting system outline, and then over a few hours, it then liquefies and then it's excreted. The pivotal study for this was the Olympus trial published in Lancet Oncology. 71 patients with 6-week induction. They treated patients with renal pelvis or calyceal tumors of up to 1.5 centimeters. And patients, some of them went on to monthly maintenance, but after the first 6 weeks of therapy, 59% of patients had a complete response, and they had around 82% durability of response at 12 months. As a result of this trial, FDA approved it for use. So we've been using it. So let me just take you how we've been doing it. And all our installations are in the clinic. We start with a cystoscopy. Majority of our patients have been done with cystoscopy. We put a guide wire in. There's a specific 7 French specially designed catheter from Urogen that is then inserted into the kidney. You have to do a retrograde pyelogram. You have to measure the tumor, the collecting system volume. You cannot instill more than 15 cc's of the gel. You do 3 measurements. You get the mean measurement, and then you get the cold liquid gel mito. You then withdraw it into a dedicated, specially designed syringe. And then it's a very thick liquid, obviously, and the catheter is specially designed, and there's a special injector called the Uroject 12-lever injector, and then that's connected to the gel containing syringe. That's then connected to the retrograde, and then catheter, and we just instill that. And the whole thing now takes us only around 10 minutes to do. Patients are completely awake, and then they just come into the clinic, and we instill that, and they're gone. So let's just talk about the outcomes for this. This is just a schema to show that, when they released it with FDA April 15th, we started that process. Dr. Morgan, Dr. Weiser at that time, and Barney, myself, we started that process. Like, we want to get that done here. It took many, many months of, as you can imagine, new cancer therapy, lots of committees, lots of processes to get approved. But eventually, folks had to be trained. The Uroject had to have a special sterilization aspect to it confirmed. But we did our first patient December 16th, 2020. I think it was you, Todd, who did that patient. So we've been doing this since December 16th, 2020 on a regular basis at Michigan Medicine. This is a schema of our first 20 patients that we have an IRB-approved registry that we're, that we're doing here for research purposes. Nick Patel is one of our medical students who's been amazing working on this project. And then you can see, I can't go into all the details, but 20 patients treated, 80% of them all did 6 weeks of installation. And then some went on to maintenance. And then let's just talk on a broad summary of what's going on here. So Olympus found that 59% complete response, Michigan Medicine 62.5%. So very similar to what was done at Olympus. The major issue in Olympus, and that has held people back, is the stenting rate. 50% of patients get stented as a result of the gel mito installation. Here at Michigan Medicine, our stenting rate is 25%. In Olympus, the permanent stenting rate, so the strictures were so bad that they had to have stents in for, was 18%. Here at Michigan Medicine, 1 out of 20 patients has needed a permanent stent. So our stenting issues are much lower. Some aspects of this therapy are logistics. It's very complex. It's an expensive therapy. They have to get insurance approval, a lot of moving parts, and it takes around at least 6 weeks from the time of saying you want to have the therapy till everything is approved and things are set in place. The other thing about logistics is we are limited at Michigan Medicine to do only 2 cases per day because you need a human to spend an hour to mix the solution, and there's no machine to do that. So pharmacy at Michigan Medicine is limited to 2 per day. Some other sites I know at Boston, they do 3 or 4, depending on the pharmacy arrangements. And then there's cost. This is a tweet from Dr. Davies when this was launched saying it was very expensive at $100,000 to $120,000 for therapy. And then, I responded, why, really? Well, explain. And I don't send you all the you can go on, there's a lot of tweets, but I case selected the tweets here. But look, Rick Matchledge said, look, yes, it's expensive, but maybe it's worth it in those specific cases and it leads to quality of life improvement. We really don't know. So there's more work and this is being done. But let me go back to that patient, 69-year-old male, gross hematuria, who ended up having a laser ablation, who ended up having gel mito. And this is his last endoscopic surveillance. Complete response, nothing in his lower pole, complete. And I treated a lot of lower pole urothelial carcinomas. They're hard to treat, lower pole. This amazing result. And I spoke to him the other day and I said, how do you feel about this? And these are his words. I cherish the ability to have a normal life. I'm able to enjoy my family and 9 grandchildren. I'm so grateful for this. I feel lucky. And then this is a video of Dr. Kaffenberger's patient who just completed his 6 weeks of induction last year. And this is what the team at Brighton did for him after he finished his 6-week induction. He didn't know. They gave him a guard of honor as he left the treatment room. He had no idea. The nursing team, the patients, this has been an amazing journey and one that I feel really fits in the vision of our department, a world free of suffering from urologic disease forever. And our mission to help people, patients, peers, community, and the world. This has been a huge operation to put together. I am just a spokesman today. All the people you can see here, I acknowledge. But I think the most important person is Trudy Reichs. Trudy, please stand up. Trudy is here. I forced her to come to the, where are you, Trudy? Trudy's our RN. She runs all the logistics, all the patient counseling, everything. She runs that. We wouldn't be able to have a successful service without her. So thank you very much. I am right on time, but I don't know if I have time for questions, so thank you.
Yeah, thanks. Beautiful lecture, Khurshid. Appreciate it. I think it's early days with gel mito, and my question to you is I think we need to hear more lectures like this nationally. My fear, truthfully, is the company's small, and in that instance, this drug is critical to the sustainability of that company. So how do you feel in terms of the ability to have this treatment become more mainstream? I mean, we've done 10 patients. We haven't written it up like you have. But I think that to me is the worry here.
If it was my dad who had this disease, I would ask him to have, of course, high grade, have an FRU, if there were select indications. From what I've seen, we did a patient yesterday, horseshoe kidney, solitary horseshoe kidney. I've been treating him for 4.5 years with the current urothelial carcinoma. And he is so, he doesn't want to lose his kidney, so he has no option. And he has a UPJ that Stuart Wolf did a pyeloplasty on, so, it's working. And we didn't want to give him gel mito because we were worried that we would convert his solitary kidney into a stricture and stenosis and all of that. But eventually, push come to shove, we gave him a 6-week therapy of gel mito through a percutaneous nephrostomy tube. He just completed that treatment. And I did his first check ureteroscopy yesterday. Nothing. First time since I've been looking after him. So, but yes, there are cases that it doesn't work. But I think, from my experience, and I think this is a valuable treatment, and it's something that I saw the negative aspects of that on social media. But from our experience, this is something that patients want to try, and we've seen some good results. Thank you, Dr. Nakata.
All right, gives me great pleasure to invite Matt Lee back. even though he's now a member of the Ohio State faculty. We won't hold that against him because he really is an Ann Arborite. Welcome, Matt.
Okay, thank you. Yes, I apologize in advance for the Ohio State background, but thanks for letting me come back. So here are my disclosures. And I thought for the talk today, I would talk about or discuss how might we evaluate BPH surgeries and discuss some controversies for modern BPH therapies, review current surgical practice patterns, and then briefly review some of the data behind MISS, aquablation, and true MISS. So what are MISS as defined by the AUA 2021 guidelines? They're minimally invasive surgical therapies that allow for office-based treatments, obviating the need for regional or general anesthesia, hospital stay, and surgery. And this is a figure you're probably all very familiar with from the 2021 guidelines. And there's so many MISS coming down the pipeline. So in the future, this average prostate category may have iTind, Eurocross, ZenFlow, Butterfly, Optilume, and the next best thing. So when we evaluated BPH therapies, there's always some sort of subjective component, such as the International Prostate Symptom Score and its corresponding quality of life score, and some sort of objective component, such as a maximum flow rate and a post-void residual. And with so many new therapies coming down the line, I think we can evaluate these from the perspective of three different players. When we're thinking about it from a health system perspective, just like Dr. Nakata talked about in his excellent grand rounds yesterday, the cost-benefit ratio. We want treatments that are cost-effective, that we can maximize treating the highest number of patients. So that's going to include treatments with a low retreatment rate. From the urologist standpoint, we want to offer therapies that our patients are going to be satisfied with and surgeries that are transferable. Not everyone wants to do a year or two fellowship to learn HOLUP like I did. And this is kind of the elephant in the room, but I think most of us are on some sort of RVU compensation model. So I think reimbursement has a consideration to take in as well. From the patient perspective, it's not just the urinary symptoms like urgency, frequency, straining. Patients care about their erectile function. Incontinence, the Michigan Incontinence Symptom Index is something I give all my patients before and after HOLUP. And ejaculation. And of course, catheter duration and if they're going to have one and for how long is also something patients are really concerned about. So just some food for thought. I think as evidence that our field is really taking the patient perspective into consideration is these two statements, statements 34 and 37, showing that prostatic urethral lift and water vapor thermal therapy can be offered to eligible patients who desire preservation of erectile and ejaculatory function. So that's a great thing. So where's the controversy? Well, as Dr. Ghani just showed, anytime you want to find, two urologists arguing with each other, you can go to Twitter. And I took the liberty of separating these tweets into two themes. And you can think about it as a team that prioritizes maximal deobstruction versus a team antegrade ejaculation. And this was all in response to a tweet on MISS. So on that right-hand side, you have some HOLUP surgeons talking about how we need to emphasize the possibility of treatment failure and how they see patients that bitterly regret going down the road of MISS and that there's not, quote unquote, victims of retrograde ejaculation, but this focus on antegrade ejaculation preservation is being driven by a multi-million-dollar MISS industry. On the other hand, you have urologists saying, no one's ever asked me for a Qmax of 26 milliliters per second or what their risk of reoperation at 20 years is going to be, and how they may talk to patients every day who are really upset about their changes in ejaculation and how this could be a really devastating side effect. So with this explosion of MISS, how is this affecting current surgical practice patterns? This was an abstract presented at World Congress this past year, where the authors looked at the Optum Labs data warehouse, between 2015 to 2019. And you can see in that top blue line, that's TURP, which was just around 50% in 2015 and decreased to just over 40% in 2019. That orange line is Urolift, and that increased from about 15% to 30% over that same time period. Although Resume only accounted for less than 10% of all BPH surgeries in this database, it still doubled over that time period. This study, the authors looked at American Board of Urology case log data, and the graph looks a little strange because the numbers were incomplete near the tail end, but I'll just draw your attention to the pink line, which represents Urolift, and the numbers just skyrocketed. And just shown another way in a stacked column graph, you can see that TURP decreased from around 53% in 2015 to 42% in 2020. And over that same time period, Urolift went from 1.6 to over 30% of BPH surgeries. When they looked at individual surgeon case log data, the volume ranged from anywhere from 100 to over 2,800 cases in 1 year. So factors associated with higher prostatic urethral lift volume, higher BPH surgical volume, andrology subspecialization, and metropolitan practice area. And interestingly, although we would think that younger patients might want to preserve their antegrade ejaculation, they did not find any association with surgeon or patient age. This was another figure presented at AUA this past year, looking at the AUA quality registry, which pulls data from over 220 different practices across the United States, mostly community practices, over 1.6 million patients in the BPH registry. And you can see in 2016, that gray bar is TURP, and 40% of surgeries decreasing down to 25% in 2021. Over that same time period, Urolift increased from 0.7% to over 30%, and is now in this database the #1 BPH surgery. HoLUP remains stable around 1% annually. So what about from the health system perspective? How is this explosion of MIS kind of affecting things? These authors performed an Excel-based budget impact model to estimate total medical costs per patient at 1 and 5 years. They obtained their clinical inputs from randomized controlled trials and cost inputs from 2021 Medicare reimbursement values. They looked at costs from 6 different states. So this figure is from year 1, and you can see that water vapor thermal therapy was cost savings versus Urolift in all 6 states. Similar results at year 5. Again, water vapor thermal therapy was cost savings compared to prostatic urethral lift. And Urolift is reimbursed per implant deployed. So what they did here was doing cost analysis, whether you put in 2 implants or the maximum of 7, or the base case, the mean number of implants put in the lift study was 4.9. And in all scenarios, water vapor thermal therapy was cost saving. So the authors concluded, compared with prostatic urethral lift, water vapor thermal therapy could potentially allow payers to cover more members without compromising outcomes or increasing budgets. Now, if you look at the author affiliations, the first 3 authors work for Boston Scientific, which manufactures Resume. So that is just some food for thought. So to briefly review some of the data behind these devices, Urolift developed in 2004, acquired by Teleflex in 2017. There's no ablation or removal of tissue. These 2 capsular tabs, one is anchored in the prostate capsule, the other pulls back on the prostate adenoma to retract open the prostatic urethra. It's AUA guideline approved for prostate sizes 30 to 80 cubic centimeters with no median lobe. And that was based on the results of the LIFT study, which was a randomized controlled trial where men were randomized to Urolift or sham across 19 different sites. And there was significant improvement in IPSS, Qmax, and quality of life without any ejaculatory dysfunction. The mean catheter duration was 0.9 days. So the FDA expanded the size indication up to 100 cubic centimeters in 2020. I have tried looking for this data. I can't find it. So I believe it's retrospective data that was submitted directly to the FDA, not peer-reviewed and not published. There's some some urologists that advocate for using UroLift in men with a median lobe, and the MedLift study looked at this in 2018, and it did show some improvements, but the outcomes were compared to historic prostatic urethral lift results, and this was not a randomized controlled trial. The AUA guideline committee really emphasized the use of RCT data, so they did not make that formal recommendation. There is also the BPH6 study, which randomized men to UroLift or TURP. This was across 10 different European centers. And the primary outcome was a composite outcome, which they defined as a high quality recovery. And more men reached that composite outcome in the UroLift arm than TURP. And again, there is no de novo ejaculatory dysfunction for prostatic urethral lift. And at 2 years, outcomes remained durable for the BPH6 study. And at 5-year outcomes for the LIFT study, again, outcomes remain relatively durable. Surgical retreatment rates were 5% at 1 year and 13.6% at 5 years. However, if you expand that definition of failure to include restarting medical therapy or removal of encrusted implants, that failure rate actually goes up to 33%. Resume, this was invented by Nixthera in Minnesota, but eventually acquired by Boston Scientific. It utilizes radiofrequency energy to basically create steam, which is then injected into the prostate and causes tissue necrosis. It's AUA guideline approved for prostate sizes 30 to 80 cubic centimeters, even if a median lobe is present. And this was based on a randomized sham-controlled trial, which we'll review the data for that on the next slide. And in that study, 30% of men had a median lobe. Can you use it for smaller or larger prostates? Again, this was not a randomized controlled trial, but there's some data for use in men with a 20 to 120 cubic centimeter prostate size showing a benefit. Going back to those outcomes, there was significant reduction in IPSS, improvement in maximum flow rates, and improvement in quality of life. The mean catheterization time was 3.4 days, and around 17% of men had dysuria for about a month. And there's no permanent anejaculation, but 3% of men reported anejaculation within 3 months. And long-term outcomes, again, durable at 5 years. About half the cohort was available for follow-up, and as shown here in that figure. And the surgical retreatment rate was 4.4%. Medical retreatment rate was 11% at 5 years. And again, no permanent erectile dysfunction or retrograde ejaculation. So aquablation, this was developed by Procept Biorobotics in California. It utilizes a robotic system and transrectal ultrasound, and then the treatment area is outlined by the surgeon, and then high pressure water jets ablate the tissue. And it's AUA guideline approved for prostate sizes 30 to 80 cubic centimeters. Oh, go back there. So these are intraoperative pictures. Basically, after general anesthesia is induced, the man is put into lithotomy position. The robotic handpiece and rigid cystoscope is inserted transurethally and then locked to the OR bed. And after an alignment process, the surgeon then maps out the treatment area and the tissue is ablated. So outcomes for aquablation, these were based on the WATER trial, which reported outcomes at 6 months. It was a multi-center randomized controlled trial comparing aquablation and TURP. And overall operative time was similar for both groups, but the mean resection time was much faster for aquablation. And aquablation was non-inferior in terms of IPSS improvement, and there was a non-inferior safety profile as well. And there were actually lower retrograde ejaculation rates reported for aquablation. Perioperative outcomes, so aquablation did have higher hemoglobin loss, 1.9 versus 1 gram of hemoglobin lost, but the mean length of stay and median catheter duration were identical for both groups. And at 1 year follow-up, outcomes remained durable with significant improvements in IPSS, maximum flow rates, and post-void residuals. So 5-year outcomes of the WATER trial, again, show durable results. And when they stratified the results by prostate size, there was a signal, as shown in that bottom figure, that TURP or aquablation may be superior to TURP for prostate sizes greater than 50 cubic centimeters. Again, low rates of retrograde ejaculation and low retreatment rates for both arms. Can you use aquablation for prostates that are larger? That's what the WATER 2 trial looked at. Use of aquablation in prostate sizes 80 to 150 cubic centimeters. Again, the guideline committee did not make this formal recommendation because it was not randomized controlled data. But there was significant improvement in IPSS and maximum flow rates. Interestingly, the mean catheter traction time was 18 hours, and the mean catheter duration was 3.9 days, and the blood transfusion rate was around 10%. So that was at a time when they were not performing any cautery. And I think in response to these outcomes, they now recommend focal bladder neck cautery at the time of aquablation, and reported results are transfusion rate less than 1%. So given that thousands of these procedures are performed, they are safe, but that's not to say bad things can't happen. In this review of the FDA Manufacturer and User Facility Device Experience Database, or MAUDE database, there were reports of blood transfusion, cystocladiovac for all three surgeries, pelvic and retroperitoneal hematomas with Urolift, rectal perforation with aquablation, bladder perforation with Urolift and Rezum, and of course, implant encrustation requiring removal with Urolift. So shifting gears to TrueMist, these are being marketed as off-the-shelf BPH therapies that can be performed at the time of flexible cystoscopy. And the primary target is not durability, but just a bridge between medical and surgical therapy. There's a ton of TMIST coming down the pipeline. I will just focus on iTind and Optilume, which are currently FDA approved. iTind is a temporary implanted nitinol device that sits in the prostatic urethra and bladder neck, invented in Israel and now acquired by Olympus. Takes about 10 minutes to perform, and it causes ischemic necrosis of the bladder neck and prostatic urethra, and it's removed after about 5 to 7 days. So in a multi-center prospective sham-controlled trial for prostate sizes 25 to 75 cubic centimeters in men without a median lobe, the primary endpoint was the percentage of men achieving at least a 3-point reduction in IPSS, and there was significant improvement with a greater proportion of men achieving that primary endpoint with iTind versus sham. But when you look at the absolute values, there's actually no statistically significant difference in IPSS between iTind and sham. And again, at 1 year follow-up compared to just baseline values, there was significant improvement, but that was not compared to sham patients. And there is no reported de novo retrograde ejaculation. Retreatment rates were low at 1 year for 4.7% medical and surgical retreatment. Optilume, this was originally designed for use in urethral strictures, and they basically modified the design. So there's a proprietary double balloon design. The first balloon sits at the bladder neck to prevent slipping. The second balloon sits in the prostatic urethra, causes an anterior commissurotomy. The balloon is coated in paclitaxel to maintain urethral patency. And the results of the Pinnacle trial, which was a prospective sham-controlled study in men with prostate size 20 to 80 cubic centimeters, showed significant reduction in IPSS, improvement in maximum flow rates, and post-void residual without any effect on erectile or ejaculatory dysfunction. And the Everest 1 trial, this was a single-arm prospective study, no control, but there's 4-year follow-up data available for that, showing durable results. So to kind of wrap things up, I think the guideline committee was very forward-thinking to include the statement that clinicians should inform patients of the possibility of treatment failure, and reported rates of retreatment are influenced by both the duration and completeness of follow-up, and retreatment may take the form of medical therapy or surgical therapy. And we just talked about how there was no permanent anejaculation, but in this prospective study from Italy presented at EAU in 22, the retrograde ejaculation rate for Rezum was almost 20%. And finally, to close in the wise words of our first speaker, we really need to emphasize the patient voice, and there's no National Association for Kidney Stone patients. There's no National Association for BPH patients. So I hope giving this talk in the future, rather than showing a slide of urologists arguing on Twitter, we can present real data of how patients feel about these outcomes. Be happy to take any questions.
We'll take one question to keep us on track.
Thank you very much for keeping me up to date on this, because I haven't done this in many decades. But I go back to the old Reed Nesbit days of TUR, and when we did a complete TUR, we emphasized really complete, and everybody had a retrograde ejaculation. And we were thinking that whether it's a big gland or a small gland, the real obstruction, the joke that Dick Dorr used to make is that you can't tell the size of the donut hole from the size of the donut. And that's because the muscle fibers of the internal vesical sphincter were intertwined with the prostate. And you're basically destroying that internal sphincter. And so you're getting almost 100% improvement, and also even improvement in nocturia because you're removing the whole prostatic mass. So I'm trying to understand what our philosophy was then in terms of all these new techniques and what they're trying to accomplish. I'm afraid that if you just leave prostate in and try to prevent retrograde ejaculation, that you maybe have eventual failure.
Yeah, I think that's a great point. And, there's all sorts of technique modifications for HOLUP, trying to preserve ejaculation, and for TURP. And there have been some interesting studies where I don't know how they got this past the IRB, but they actually filmed real-time transrectal ultrasound footage while men were ejaculating. And there's some data to suggest that it might be the anterior prostatic tissue. So there's like two schools of thought, like, is it the bladder neck preservation, like you mentioned, with the muscle fibers that maintains antegrade ejaculation, or is it this anterior tissue kind of around the verumontanum that is, so in that transrectal ultrasound footage, they saw that the verumontanum got pushed forward and made contact with the anterior prostate tissue. So those authors were saying it's not so much the bladder neck, it's this anterior prostate tissue. But I'm kind of on the same boat as you, just open it all up and just set the right expectations for the patient. Obviously, if it's someone that really desires antegrade ejaculation preservation, you're not going to recommend a HOLUP. Yeah.
Thanks, Dr. Lee. Really comprehensive review. I now know why someone thought I was from Ohio State. And if they're confusing us, I'm winning, I think. But my question is, simple, but two-part. One is, are there too many treatments here? And then number two, what do you recommend, in the garden variety BPH case where someone needs a procedure?
Yeah. There was, again, an excellent discussion on Twitter about, is there too many therapies? Is it becoming too unmanageable for urologists to be experts at all these different therapies? And a couple different experts chimed in, including Dr. Casey Dow. And basically the consensus was, just be comfortable with a couple. You have partners. So I only do HOLUPs. And if someone wants a Resume or Urolift, I'll send them to one of my partners. And the second part of the question, so what do I offer? I mean, if you go back to that figure for the 2021 guidelines, and, I was trained by Dr. Krambeck, it's HOLUP for everyone pretty much because it's a size-independent treatment option. But obviously, you have a discussion with the patient, figure out what their goals are. And if ejaculation is very important to them, I won't, recommend that. I'll send them to one of my partners for a MIST. Thank you.
Next, we're inviting to the floor Caleb Nelson, who I also had the pleasure of working with in the distant past. He's Associate Professor of Surgery and Pediatrics at the Harvard Medical School and also the Director of Quality and Safety. And it's my great honor to have him speak about the Montie years.
Thank you, Mady. Thank you to everyone for this invitation. I see that Dr. Montie is here in the audience. I was a little nervous that he would be here, but when I got this invitation, I was very honored, and I asked, well, what kind of talk are you thinking about? And they just, Mady said, well, time goes by, and it turns out that some of the younger people in our department don't even really remember the Montie years, and so we wanted to kind of revisit that and tell people how essential that was, and that it took me back to when I was a fellow at Hopkins. I was there during the transition from Pat Walsh to Alan Parton, and after he had stepped down, people would ask Dr. Walsh, they would say, what's it like? How are you doing since you stepped down? And he said, well, it's surprising how fast you go from who's who to who's he. And so that reminded me of this a little bit. So I think I have no disclosures. So James Montie, who is Dr. Montie? So Dr. Montie was born in Detroit and grew up in Ecorse. Am I saying that right? Is that how you pronounce that? Ecorse, for those of you who don't know, is right about there. And it's just south of the River Rouge plant. So I would imagine there were a lot of Ford Motor employees or Ford's employees there at the time. He attended this local college. I think it's south of here. I did very well, obviously, but apparently the football program was not sufficient for his tastes. So he decided to come to medical school at the University of Michigan. Dr. Montie then did sort of the usual crisscrossing the country as training proceeds. He was an intern in Seattle. He did his residency at the Cleveland Clinic. He then spent 2 years in the Air Force, focused primarily on transplant, from what I've read, and then went to Memorial Sloan Kettering for his oncology fellowship. And as a resident here, when Dr. Montie was here, I was unaware he had done any training anywhere ever except at Memorial, because that is what he talked about all the time. And when we were at Memorial, this is what we did. He then spent about a decade at the Cleveland Clinic as faculty, and then spent 2 years down in Florida, taking over the Cleveland Clinic Florida urology program. But Florida didn't sit well with Dr. Montie. He's a Midwesterner, and so eventually decided that was the wrong place, came back and spent some time at Wayne State University. So how did Dr. Montie come to Michigan? Well, if you go back in the day, around 1993, the chief of the section of urology here was a urologic oncologist named Bart Grossman, very well known. He was the interim section chief. And in 1994, Joe Osterling was selected to be the chief of the section of urology. And later that same year, the town wasn't big enough for both of them, so Dr. Grossman left to go to MD Anderson. And that left a bit of a hole in the urologic oncology program here. It's probably hard for anyone who's a resident here now to imagine that one guy leaving would make a difference. But at that time, that was a big loss. And so Dr. Osterling looked around and realized that Dr. Montie was just down the road, and so recruited Dr. Montie to come here to run the urologic oncology aspect of the program. And so Dr. Montie came. Now, shortly thereafter, Dr. Osterling left Michigan, resigned in 1997, and at that time, Dr. Montie was named the interim head of the section of urology. And so shortly after that, he became the permanent head of the section, and then very importantly, the head of the chairman of the Department of Urology from 2001 until 2007 when he stepped down. So urology back under Dr. Montie during that 10-year period was a very dynamic time. Dr. Montie had very high expectations and made that clear to everyone. We all knew that. And I think we had a resident cohort at the time that really wanted to fulfill that expectation. People worked very hard. People really, really wanted to achieve and do well. We did change the residency system at that time under Dr. Montie to a more of an apprentice-based system from just two big teams, and you're either on the indigo or the orange team. It was much more of an apprentice style. So you would spend 3 months with Dr. McGuire, you'd spend 3 months with Dr. Wolf doing laparoscopy. Another big focus was that academics really came up and became a real priority and was emphasized and it was really conveyed to the trainees that this was a central part of what we did. We're here to learn how to be urologists, but we're also here to learn how to move urology forward. And it really created a lot of motivation and excitement for people to really be involved in that. I think another big element of it was that Dr. Montie, you lead from the top, you lead by example. And so the creation of a culture of respect, collegiality, and really creating an environment that people liked to be in and could thrive in was really central. And he really, I think, was almost single-handedly responsible for doing that. And then, of course, there was a big focus on oncology. That's where the focus was, because that was his world, and it inspired countless trainees, not myself, but countless other trainees to go into urologic oncology. And if you look at the urology world now around the country, around the world in many ways, the descendants of that they're everywhere. So lessons learned under Montie. What was it like to work under Dr. Montie? He really emphasized being meticulous. He really emphasized checking every box, dotting every I, and crossing every T, not for the sake of doing that, but because that's how you provide good care. I remember once there was a patient on the service, and they were not doing well. They were having fevers, and nobody could figure out where the fevers were coming from. And we get chest x-rays, and they did lab tests and blah, blah, blah. And eventually Dr. Montie came up on the floor and did an actual exam and found a raging epididymitis that would have been hard to miss, but no one had done due diligence to find it. And once we had a source, it got treated. And that was just emblematic of the fact that you have to do it right every time. You have to make sure you dot those I's and cross those T's if you're gonna provide good care. Let me see here. Whoop. Sorry. All right. Patients. This may seem obvious, but it's not always obvious in a surgical service, and it certainly wasn't obvious on surgical services in the 80s and 90s. But patients are people, right? And you got to treat them like people. The thing that I always remembered was when we'd go on rounds and Dr. Montie would go into the patient's room post-op day 3 from a cystectomy, he'd just go over and sit down on their bed and start talking to them. And I had never seen that before. I'd never seen anyone kind of get down on the patient's level. I've seen others who've done it since, but I'd never seen that before at the time. And it really struck me that he was making himself open to the patient. He was making himself in their environment. I suspect that our infection control people wouldn't be happy with that practice nowadays. But the principle still applies. And pull up a chair, sit down with the patient, talk to them like they're not just a surgical patient. And I think that struck me, and it's always stuck with me. Integrity is everything, and in part this is due to Dr. Montie's intrinsic integrity, of course, but coming in under the circumstances that he came in, taking over a department that was sort of on the brink of free fall, and having to restore the sense of mission, having to restore the sense that this was a place that was built on honesty and doing good work was essential. And so that from a timing standpoint, that was really key. But even years later, it still was a central element of the mission, and we got that message in a million different ways. But I think it was critical, and setting the tone again, it all starts from the top, right? It all comes down from the top. And understanding that honesty and due diligence and making sure that you're doing the right thing every time, whenever it's possible, that came down from the top. And I think it was essential to bringing in new people. It was essential to expanding the department. I mean, people who joined the University of Michigan in the past 18 months, I think it's probably hard to imagine how much smaller this place was in 2003, in 1997. It's a transformative period, that 10 years, that it became not just bigger, but it became a national presence at a scale that had never really been even envisioned before. And without this, without that commitment to the integrity of the care, of the science, of the education, that wouldn't have happened. I think when Dr. Montie was the chief, it was a fun place to be. Not just because we had an amazing cohort of residents and fellows, many of whom are here, but because Dr. Montie and the other faculty who we had really conveyed this idea that we're doing fun stuff. This is exciting. We're creating new knowledge. We are doing things that will, that it will advance your career, but it's actually going to make differences in the lives of patients everywhere around the world. And that created this idea of really feeling like we were part of something that was great to be part of. And that does not happen everywhere. I can guarantee you that. And that was a unique and very special time to be part of this group. Dr. Montie did, big whacks, as they say, big cystectomies in 90-year-olds, big pelvic tumors that were attached to everything. And we used to talk about this, and I took away this message that this is a fact of life. When you do big cases, you're going to have complications. You're going to have big complications. And obviously, you have to do your QI. You have to figure out your root causes. You have to figure out what you did wrong, if you did anything wrong. But you have to also come at this with the mentality that these treatments need to happen if you're going to give these patients a chance. And if you're gonna be able to come to work every day, month after month, year after year, and do this kind of thing, you have to understand that these things are going to happen, and you can't let it destroy you and make you a non-functional as a surgeon. You have to be able to compartmentalize these things and understand that if you do this kind of risky stuff, you're going to have to deal with the consequences of that. And it's sobering, but it's also liberating, because you understand that even the great surgeons, even the people that you've watched do things that you didn't think anyone could do, if anyone in the world can do it, this guy can do it. But even this guy has outcomes that aren't ideal, and you have to come to terms with that. One thing I just remember, we used to do open radical prostatectomies, and you'd be one person on one side, one person on the other. You'd be peering down into the pelvis, and the resident would be doing what they can do, and they're going and going and going, and then after a little while, you'd just hear switch, and you'd back up, you'd unhook the headlights and walk to the other side of the table, and Dr. Montie would come around to your side of the table, and he would finish the operation. And it was always, a question of how far are you going to get in this operation before you have to do the switch. And that's all. Some of it's time, some of it's impatience, but most of it's just we have to do the best job we can for this patient, and the trainee can only get so far. I learned just this is obvious now, I guess, but if you're not a department and you're a urology group, you're in a tough spot. And this transition happened during the Montie years. It essentially was not a precondition of his taking the job here, I think, but it was understood to be a given. And I think the transition from a section of another department to a freestanding department was what allowed this department to to blossom and become what it is today. And that, whether that would have happened without Dr. Montie, I don't know. It wouldn't have happened when it happened. And this place wouldn't be what it is now without that transition. Lastly, you just have to show up, right? You have to be there, you have to be present, and you have to do the work. And sometimes it's just a slog. You just have to keep pushing through, and that's what you do. I forever will remember the time I woke up at maybe 2 a.m. and my pager is on the bedside, and I look and I've already gotten 3 pages. I said, oh no. And so I called, and there's a patient in clot retention, and I get in the car, I drive in. This is when we did home call, and I drive into the ER, and it's literally the middle of the night. I get into the room, and Dr. Montie is standing there in the patient's room doing a clot irrigation on this patient that he knew very well. And that is not a good feeling to have when you are the resident. But he showed up. He was there, and made me look like a not a good night, but never forgot it. And it was a moment. And then medicine is not everything. Urology is not everything. Have interests and a life outside of what we do. And for those who don't know, Dr. Montie is a national champion rower, and spent many years on his shell on the water, and I think that probably is what kept him sane. So it's been a privilege to be here, bring a little bit of the Department of Urology under Dr. Montie back in the day to those who weren't there at the time. So thank you very much for inviting me.
Thank you very much. That's an awesome story. Oh, there you go. Rebuttal. Uh-oh. We got to throw the box.
I have to make a comment. That's a horrible talk. And I was afraid when I saw the topic that you were going to put up one blank slide for 15 minutes. And lessons learned. But to me, one of the key principles as the group grew and tried to instill in everybody in the faculty and the residents the difference between residents and fellows and the faculty is age. The residents and fellows are just as dedicated to try to take care of the patient as best they can to succeed academically. And so if that difference is just age, then there's a mutual respect that ought to take place. And I think that it's a good concept and one that I'm sure is continued today under Ganesh and the rest of the crew. Thanks, Caleb. Where'd you go? Thank you.
I thought he was going to bring up the story of the swear jar. Well, thank you very much, Caleb. That was an awesome talk. Next, I'd invite to the stage Jay Hollander. Jay was the junior resident to my partner, Hugh Solomon. And when I was in practice, and you trained here as well, had stories about Jay, and I thought, wow. So when I finally went to Beaumont to work with Dr. Diokno and his group there, I finally got to meet Jay. So he's got some great stories of his own. So welcome to the stage.
Thank you, Mady, for inviting me here, Dr. Way, Dr. Palapattu. I actually wrote a speech kind of like this a couple years ago when the 100th anniversary of the Nesbit was to occur. Excuse me. I had one of these things. I had a terrible reactive bronchitis,
and I couldn't come. It doubled the length of my speech. I was coughing so much. And if I was coughing like this, you guys have been out of here in about 15 seconds in the age of COVID. At any rate, I am particularly, first of all, that's last talk, great talk, inspirational talk. And I agreed with every bit of it. Dr. Akata is here, and I'm especially pleased to be here in his presence. A close friend of mine when I was active in the North Central section. One of my favorite academic urologists, Montie. You were one of them too, by the way. And he's one of the, I remember years ago telling Steve, hey, you're going to be president of the AUA one day. And he's only the other person, there's only one other person I told was president of the AUA. Of the two, Bob Flanagan, another person I have great admiration for. So I picked two guys that I told years ago they're going to be president of the AUA. They became president of the AUA. And if I bump into anybody later on and tell you you're going to be president of the AUA, you better get ready. I finished my residency in 1984 and then did a year in Minnesota in the Twin Cities where I did a 1 year as an attending and teacher before I came to Beaumont. By the way, Nitin Ambani was my chief resident back then. And I did enjoy that year and still feel close to the guys that were there, as do you, I suppose. I then spent 35 years at Beaumont as director of urologic education or program director. And I wanted to talk about the impact that training here at the U had on me when I was a resident. My mom and dad were teachers. My dad was a principal. I was well behaved. I had two uncles who were doctors. They were not surgeons. And when I was a kid, I used to play with that game Operation. And I fancied myself, if I grow up, maybe a teacher, maybe a doctor. But if I'm a doctor, I want to be a surgeon. When I got to the University of Michigan for undergrad, I went here for undergrad, I realized I could not be a surgeon from the School of Education, but I could be a teacher out of the School of Medicine. I actually ended up going to medical school here at the university. And when I did, I decided that the surgical subspecialty most attracted to me was urology. And at the time, the university wanted you to have a mentor, somebody who could be your, guide you and tell you, hey, is it realistic that you could even get into the program? And I went down to the cysto suite at the old university hospital, which doesn't exist today. And I went down to see this, the resident doing cystos. It was a guy named Lenny Zuckerman. I don't know if Lenny's here, but Lenny said to me, you know, if you want somebody as a good teacher, I would recommend Ananias Diokno, who, by the way, is here today. And that began a 45-year relationship where Dr. Diokno served as my mentor as a medical student, as my instructor and favorite professor at the university when I did residency. He was my chair and partner when I went to Beaumont. And later on, he became the chief medical officer for the entire system, and therefore was my boss. And I've known Ananias almost as long as I've known my wife. And I guess you're my second favorite boss. My third year in medical school, having, if you have integrity, if you're honest with yourself, if you have a conscience, you cannot be a surgeon without competence and confidence. And lacking confidence and competence was exactly me as I started my first 2-month rotation in general surgery, and it was in urology at the VA. I had the mindset that I think I was feeling so insecure. I felt like I was a a medical student, a senior resident, excuse me, a senior medical, fourth year medical student on the medicine service. That's how I felt. I was just working up these sick VA patients for surgery and taking care of them during their hospitalization or post-op. And I had the mindset of a medical student, and it was taking me forever. And it was work all day and into the night. And I was checking and double checking everything to make sure I wasn't missing anything. And oh my God, these guys could die. They're so sick, they're going to the OR. And I spun it in a way that it made it really tough. And I was experiencing sadness and unhappiness that I had not felt before. And here I am on a urology. Oh my God, am I going to have to, what if I fail? And that was noticed by my chief resident. And the chief resident was Hugh Solomon. And Hugh sat me down and said, you know, you're doing a good job. It takes forever because this is internship. And I remember when I was younger, I went through the same thing. And I'm telling you that though you feel like you're in a tunnel, you're going to get out of that tunnel. There's going to be a light at the end of the tunnel. And I really appreciate his caring, but I still didn't feel too well. It was just so hard for me to get through the day. It took forever, but there's one good thing is I did finish my work at the end of the day, and I did to care, make sure I wasn't missing anything. My wife and I realized I was getting exhausted by the stress, and we decided I would get counseling. And I got counseling at the University of Michigan offices that had a psychiatrist that specialized in medical residents and medical students and residents. And he sat me down and he said, what do you do? I said, I'm doing my internship in urology. And I told him everything I did. I told him the hours I worked and call I did. And he said, are you doing your job? I said, yeah, but it's taken me forever, and I hate it. You know, I feel like I'm a med student in internal medicine, and I hated internal medicine. He said, what does your chief resident say? He said, he thinks I'm doing a good job. He thinks I'm doing a good job, but it doesn't feel like it. And he looked at me, he said, you know, you're a normal guy. I said, what? He says, no one wants to do your job. No doctor in the world wants to do your job. And you know what? You're supposed to feel lousy because internship feels lousy and surgical internship is the worst. And he said, you're doing your job and you're hanging in there. And you know what? You are a success. And when he said success, a light went on. And he gave me a few more sessions, but week by week by week, I got feeling better and better. By the end of the rotation, I felt like I fit. And I felt like I was a doctor, and I felt I could be a resident. The amount that you can learn when you feel better about yourself, when you are happy, is unbelievably different than if you feel sad. And lots of surgeons feel sad, you just don't know it. I remember that so significantly that when I got to be program director, when I got to work with Dr. Diokno, every time I had an annual orientation of my residents, I told them about this story, and I told them my door was open, and I told them they could have automatic confidential counseling. No one would know about it, but don't keep it inside. And I told my residents, you look after each other. This is tough. You back each other, you help each other, and you will do better. You will do better that way. Physician well-being is not to be discounted. It is major, and I wanted to emphasize that to my residents. Another thing was rest. Man, we're tired when you're doing internship. You're tired all residency. But sometimes you're tired to the degree that is dangerous. And I don't mean dangerous for patients, because I remember, as tired as I was, I don't remember making too many mistakes with patient care. But boy, do I remember being scared driving home from the county when I was on call all night. You know, the county hospital doesn't exist anymore, but it was about a half an hour from the university, and you had to drive this long drive from Michigan Avenue to Getty's to get home. And what would happen is you'd be at the hospital on call every other night. So when you're up, you might be up all night on call. Then the next day you're working and you don't get out till the afternoon, and then you got to drive home. Man, you unroll the windows, you turn the radio on, and you're worried you're going to drive off the road. And there is no one who worked during my years at the county. Gillette, do you remember this? Lots of stories of people going off the road. Lots of stories of people having accidents, concussions, and a death. When I got into training my residents, I made sure my chief resident knew if somebody was up all night. If they were up all night, I wanted them to get home as soon as they could safely. And when duty hours came out, a lot of surgeons bitched about the duty hours. I agreed with a lot of the duty hours. Some of them not, but there's no question that resident rest was critical to their safety. So physician well-being, yes, both psychological, emotional, and physical was a priority for me. I did my next 2 years of general surgery and really did enjoy that. I learned a ton about medical care. Man, we learned too much about it. We were like ICU docs at the end of that rotation, at the end of those rotations. One thing I learned that was very important was the importance of teamwork. I really enjoyed the team concept of rounding. And I really enjoyed how residents taught each other and how we backed each other, how we supported each other. And it was like Schembechler, team, team, team. I really did find that valuable. And I found that valuable in my training where, when I was training the residents, I would definitely round as a team, and I would round in a way that we related to each other and had an environment that helped with educating and teaching each other as we rounded. I've been retired for 3 years now, and it's absolutely true. You go from who's who to who's he, and that's at my own institution. And I remember back to the professors and the instructors that I had when I was doing my surgery here at the U. And I don't remember how famous they were as much, or what kind of surgeon they were. You know what I remember is how did they make people feel? How did they treat people? Was there humility or arrogance? By the way, Montie, role model for humility. Was there patience or impatience and anger if things weren't working out quite right? By the way, Diokno, model for patience, model for patience. Was there fairness or unfairness? Was there constructive criticism or destructive criticism? Was there a sense of humor? Sense of humor is very helpful. Good sense of humor, really helpful. For those of you who are teachers of residents or program directors, spend time with your patients, spend time with your residents teaching, advocate for your residents. If you do so, they will show loyalty to you. They will remember you for the impact you had on them, not for what kind of career you had or how famous you became. They will remember for the impact you had on them. Be a good role model. They're talking about, way back when Montie was chief. Well, my chief was Lapides. Lapides was chief for the first 3 years, and for the first 3 years, I never talked to him. I don't remember anything. I guess once I was on the elevator, I walk in, I'm like my second year, and I walk in and oh my God, it's Lapides with his nurse and she's carrying his records and nobody else is on the elevator. I said, "Hi, Dr. Lapides." And I looked down, I saw he had new brown wingtip shoes. I said, "Nice shoes." He looked down at his shoes, he looked up at me, he smiled and said, "Why, thank you." I thought we were friends from then on. Lapides was an old man with white hair, bushy eyebrows. Everybody was scared of him. I wasn't scared of him. I'm older than he is now, than he was at that time. I'm about 3 years older than he was at that time. Lapides, however, had a significant impact on me. Remember the word impact. I hardly talked to him. By the way, I couldn't believe it. I hardly, did you talk to him? Yeah, a couple times. That was it. I talked to Steve Kowalski, he's my chief resident. I said, Steve, did you ever talk to Lapides? Am I remembering wrong? He says, one time, I think I asked him a question from a clinic where the attending wasn't there, but I do remember operating with him. I don't remember operating with him. I said, what happened? He says, well, you know, Lapides was 5'2", and Steve was about 6'4". And Steve said, I was operating with him for 2 hours while he was doing open operation on a bladder. My back was killing me, which brings up another point. When I had my residents walk into the OR, I wanted them to know the case, be prepared for the case, know how to position the table, know where you were going to stand, which side do you want, and is everybody comfortable and ready to go? Is everybody comfortable, ready to go? I think Steve was a little chicken. He didn't have the guts to say, Dr. Lapides, could you raise the table a foot and get on 3 lifts? Lapides, however, did have a great impact, and the impact was this. We had what was called intravenous pyelogram conference. You didn't say IVP. It was intravenous pyelogram. There were no abbreviation. He was a detail guy, too, and you needed to be complete. You needed to know your patient, all the data about the patient, have all the x-rays, and review them, and that is stuck in my head because I do that every time before every case. Lapides wanted details to the degree that he couldn't say the creatinine was 2. The creatinine was 2 milligrams %, or 2 milligrams per deciliter of serum. You had to tell him that the creatinine clearance was 70, or that you couldn't say that. You had to say the creatinine clearance was 100 cc's per minute, Dr. Lapides. At any rate, the presentation was complete so everyone in the room could actually have a feel of what's the next case. Now, we could do, again, difficult cases and how to manage them, or difficult complications and were they managed well. And what the whole conference was about was Lapides looking to his left and his right, picking the senior attendings first and then going down the list and actually thinking through what was best for the patient, what could best be done for the patient, how could the complication have been avoided, what is best for the future, what have we learned from this, and there was no pointing of fingers. And at that conference, I learned a tremendous amount about the word judgment. Judgment is as helpful to me a tool. As limited as I thought I was with my hands, I was really good at judgment. You put those two together and you can do some real good urology. My feeling was that judgment helped not only with how to best treat the patient, but also how to manage complications. If you had good judgment, you could manage complications well too, and we're all going to have complications. Another thing which brings up complications, and it was mentioned in a previous lecture about the suffering that physicians into with complications, and how it can weigh on their mind, and it can be something that can really be deleterious to their functioning, depending on the type of complication. My viewpoint was the same. Complications will occur. And how do I mitigate the suffering? My personal suffering. You mitigate that by being positive, by saying you are the best to manage this complication, and you do everything you can to help that patient. And that positive attitude and that competence and confidence helps the patient and helps the family. They want to know, okay, he can help me. Complications will occur. I knew they might occur. They did, but he's going to help me. And that was very important for me to manage that difficulty when complications do occur. You know, I trained residents to maintain competencies in fund of knowledge, patient care, professionalism, and surgical skills. I wanted them to maintain them because you have to continue to maintain them and get better. When they were ready to graduate, I would say, you are ready to do surgery independently, urologic surgery independently and without supervision, but you will have the judgment as to when to get help and the judgment when to refer. And you will never be doing surgery unless you feel competent and confident. I trained in an era when all surgery in the abdominal cavity and pelvis, all surgical procedures were open. They were all open. When I trained, or since I've trained, everything I did surgically is almost not being done today. The only thing that I can think of is these huge tumors, cable thrombosis. I still wanted to do those open, but otherwise, no, everything's done. I had to learn everything new again. Lifelong learning is real, even if you don't like the thought of it. God, I got to go to school for the rest of my life. No, you are learning stuff all along as you go, and your career will be totally different when you get to my age. The things that I learned, when I think of what I learned, and I'm going to tell you, it's not only the academic or how to learn it, but the marvel of, oh my God, I can't believe I can learn this. Remember, when I was starting residency, I was doing blind basketing of stones. First thing I saw a ureteroscope, oh my God, this is after residency. Oh my God, I can see a stone and I can actually put the basket around as I'm watching. Oh my God. Then I discovered you could actually take a telescope and look all the way up into the kidney. Oh my God, and then a flexible scope where I could curve and go down into the lower pole, grab the stone, put it into the upper pole. What? And then there's this thing called a laser. It breaks up these stones. And then there's this thing called ESWL. Who's the genius that figured that out? This is like magic. I can't believe it happens. Percutaneous nephrostomal lithotomy. When I was a resident, I'd take a big incision here. I'd open up that kidney to expose it, cut the kidney in half, and pull that big staghorn. Or if I was lucky, I could do an extended pyelolithotomy and not do that nephrotomy. What? You can put a tube in and you can suck that stone out? I just can't believe that happened. And you had to learn all of that. Everything I've told you, I learned after residency. I was incompetent. I had to develop competence and confidence and then teach. The teaching urologist must be continually learning if he wants to continue teaching. We advanced to laparoscopy. We advanced to hand-assisted operations. My favorite operation, by the way, hand-assisted kidney surgery, hand-assisted radical nephrectomy, hand-assisted donor surgery. I just couldn't believe how good you could see. I couldn't believe, by the way, you think you're all fancy guys doing this robotic stuff and laparoscopic. You know what you're lucky about? Pneumoperitoneum mitigates blood loss and makes things a lot easier and you can move a lot quicker. Magnification helps tremendously, tremendously. I ended up stopping my major stuff when I was about 63. I said, there's too many guys doing all this. I'm not doing each case frequently enough. That's the one thing about robotics. After I did robotic prostatectomy, I was done doing radical prostatectomies. But when kidney surgery came for with robotics, I was done. I gave it away. But I have great respect for the way urology progresses. It's such an advanced field in terms of being leaders in these technologies. And we're lucky to be part of it. I had a wonderful career and loved patient care as much as teaching residents. I remember when taking care of patients, always try to do the right thing. The best care comes from caring for the patient. And I want to dedicate this talk to memory of my friend, colleague Joe Salas. Joe was a member of the University of Michigan towards the end of his career. He trained with us at Beaumont, graduating in 1991. He died after a courageous 13-year battle with prostate cancer at the age of 64. He asked me, by the way, when it first was diagnosed, where should he go in the country? And I said, he has to go here. I remember talking to Jim Montie about him, and he did get his initial treatment here. He was 64 when he passed. He was solid as a rock, as a resident, urologist, and person. I will miss Joe. Thank you.
Thank you for those words of wisdom. Now, it's my pleasure to invite Dr. Silber to the stage. Also, a COVID-delayed talk. Oh, don't scare me like that.
I've got my water and I've got my timer here. Guess the water slipped down a little bit, made a mess. Okay, this is great. I am so delighted to be back as I was greeted by Ganesh. Welcome home. It's great to be welcome home. I graduated residency in 1973. I trained under Jack Lapidus, but also had a tremendous amount of training even after he was no longer chief by the original Reed Nesbit. And so I'm going to walk you through a tour of how your life can change because we're taught at Michigan, I was always taught to keep your mind open and to follow whatever stream, whatever tributary in the river you see at the moment might have the greatest intellectual possibilities, even if you leave behind what you were originally trained at. Your most important training was learning how to learn and how to stay open. So let me just see if I can. This should go to the first slide. Oh, well, I'll go backwards for a second. Let me go back here. Yeah. Okay, so this is from TURP to making sperm and eggs from skin cells. And I guess I'd like to see my own slides so I know what I'm talking about, actually. So I'll stand sideways. And the first, I'm going to just start you with a video that's going to be very heartwarming that is not going to be what we learned originally in our urology training, but shows you how far we can go with the methodology and the thinking processes I was taught here in our urology department. So this is a video with sound.
I think that there's never been any doubt in my mind that I wouldn't be cured of this. Once I found out, I just made up my mind, that's it. You just have to keep taking it one day at a time and just keep that positive attitude and know that I can do this. I'll get through it.
It's 8 o'clock in the morning, July 17th, 1997. We're at St. Luke's Hospital, and we're about to do the first case in the St. Louis area of ovarian tissue freezing. Okay, well, I'm Dr. Silber, Sherman Silber, the Infertility Center of St. Louis, and we really have a treat right now. This is Jennifer, who at 24 years of age, I'm right on that, yes, right, came down with a terrible case of leukemia. They thought she was going to die, but just to be safe, in case she lived, when she did, and was cured, we would freeze her ovarian tissue. So that was like 20 years ago. And this is the first case that we ever did, and we're the only ones right now really actively with a program in the whole United States. And it's been a long time, and we didn't know that we'd be able to transplant the tissue back, and we didn't know if we could culture the tissue. And here she is now. We had her on Facebook Live several months ago, and she was happily pregnant, and now look what we have. Now she's 44 years old, if I can reveal that, with a 24-year-old ovary and a beautiful baby. What's her name again?
Madeline Grace.
Madeline Grace.
So this is where we wound up, and we started out. My first book was on transurethral resection, which was guided very much by Reed Nesbit. At Michigan, there was some confusion about whether to do your TUR starting at 7 o'clock and 9 o'clock to control the blood supply, supposedly, or to go with the original Nesbit method. So I wanted to repopularize the Nesbit method, which I felt really works better and is easier to teach.
Transurethral resection of the prostate is the most common procedure urologists perform. Yet it is also the most difficult. It is a closed procedure viewed by a single person in which no assistance is possible. There is no retractor to help expose the area of concern, and the smallest bleeders can obscure one's view. An inexpertly performed TUR can be devastating. Incontinence, recurrent obstruction, blood loss, extravasation, and sepsis can make this a harrowing operation to teach. The method I'm about to describe is an anatomic one, which I believe makes transurethral resection easier. It is basically a version of the original technique described by Reed Nesbit many years ago.
So the point I want to make here is that this movie that I did in 1974, just after finishing my residency, won first prize at the AUA. And you may not understand that if you're younger, how impossible it was to make this movie, because we didn't have chip cameras. We had great big television cameras, or we had these 16mm Beloos, and we didn't have any kind of a teaching attachment or fiber optics. There was just a long stick with a mirror that we could attach to the camera and to the scope. And when you turned the scope around like this, the resident who was holding the camera had to get up on a step ladder and follow your movements with the Bolu movie camera, and you had to change the film every 5 minutes. And then editing was on a board with strips of film, and so everybody thought it was impossible. But this is a real great achievement, and so we won first prize for this video.
We will now demonstrate the endoscopic anatomy of the urethra and the prostatic fossa carefully several times. This is the bulbous urethra, the membranous urethra, the viromontanum, the membranous. If one creates an adequate groove at 12 o'clock, right down to the fibers of the capsule, visualizing always with these long, smooth strokes the full extent of the prostatic urethra, exposure is excellent and hemostasis is easy to maintain.
So, actually, when I went to University of California, San Francisco, after leaving Michigan, they had no idea how to do TUR. So I came from the holy center of TUR, and I taught them this and popularized it. And at that point, TUR, they were actually still doing open suprapubic prostatectomies for benign prostatic hyperplasia. So I owe a tremendous amount to Reed Nesbit, the original Reed Nesbit, for my initial learning, and then to Jack Lapides for teaching me discipline. Now, from there, we went to microsurgery, which all came from University of Michigan, too. Jimmy Crudup, no education beyond high school. He was an African-American janitor in the lab that we had free access to, because University of Michigan had this huge fund, the Babcock Fund, that allowed us to do almost any research we wanted to do. And instead of working on dogs, which was the common surgery that day, surgical research was always on dogs, we went to rats and mice because we wanted the largest animal sufficiently inbred that we really could determine transplant rejection, and we could actually put extra kidneys into rats. So here I am with the famous Jimmy Crudup, and that's his assistant on the right, and I'm the little guy in the middle. But Jimmy Crudup was, I think, well, he was acknowledged as probably the best technical surgeon at the University of Michigan ever. And he was finally granted a PhD for this just before or just about when he was dying, and he's passed away now. But I'd like to show you this program that we did for Jimmy on the Today Show.
I heard some of the older surgeons talking about this amazing guy, Jimmy. He just watched what these guys were doing, and he did it better than them.
Sherman Silber was a Michigan med student in the 1960s, struggling when he asked Jimmy for help.
I was terrified because I had no manual ability whatsoever.
Dr. Silber became one of the pioneers of microsurgery, now one of the leading fertility specialists. techniques he perfected with tools Jimmy made for him.
Jimmy explained to me it's all in the mind, in the brain. It's not really in the hands.
They practiced on rats.
Once you could do a heart transplant on a rat, it's not a big deal to do a testicle transplant on a human.
So now we'll get a little bit back to that, but I point out three major teachers I had at Michigan. Jimmy Crudup, the basically uneducated African-American janitor who was the best surgeon at the university. And this was a surgery department, by the way, that was well known around the world for surgical technique, not just pre- and post-operative management, but we were well known for being the best surgical technicians. And Jack Lapidus for discipline, Reed Nesbit, who began my career in endoscopic surgery. Now, this is just, I'll run through these slides quickly because I don't want to go over my time, but this was actually, these are illustrations done at the University of Michigan's art department of what our first experiment was together in microsurgery, which started everything that I did after that. This was putting an extra kidney into a rat. We knew that they were syngeneic and they wouldn't reject, and we understood compensatory hypertrophy to some extent, but I thought the only way to really understand it is if you put extra kidneys into a rat and see if the kidneys would shrink in size. And I did that with Richard Malvin at the nephrology department, and Jimmy and I did these transplants. We were the first people to do these transplants in rats. There's the IVP of the first rat that we did. And what we found measuring GFR and RPF was that these animals had 3 times or 4 times normal renal function. There was no hypotrophy. So we wrote a very famous paper in the American Journal of Physiology, Silber and Malvin and Crudup. And Crudup was on every paper that I wrote, and there's a difference between compensatory and obligatory renal growth. And so we went from there to then beginning to apply this clinically. So we wanted to salvage the fertility of the high cryptorchid testes in children. And I worked in Melbourne with the famous Douglas Stevens, who was at that time the leading pediatric urologist in the world. And he wanted me to do this. He developed the Fowler-Stevens operation for the high testes, but he felt it didn't work very well because over half of those testes would hypotrophy. So I just want to show you, this is, you don't have to read this letter, I'll show you some slides of how this came back to me just last year, so I want to include it. These were things that I were doing in the 80s with the microsurgery I learned at Michigan. So this is a letter that came out of nowhere from this mother, in which she said, unfortunately, although the first surgery of her little 2-year-old first appeared successful, little by little the testes began to shrink. And that is what happens with the Fowler-Stevens procedure. This left our son with only 1 remaining testicle, which was still in his abdomen. We were told he would never have children. So I asked for an outside opinion, and that led to me, because I had done testicle transplants, I'm getting ahead of my game a little bit, for men who were anorchic. And so they thought maybe I could do a testicle autotransplant, which we had reported on in Australia when I worked with Fowler-Stevens. And all of you should know, because you all talk about the Fowler-Stevens procedure being so great. Fowler and Stevens hated their procedure, and they asked me to actually modify it with microsurgery. So now he's a 45-year-old father of 2 beautiful children. There he is when he was just a 5-year-old when I did the testicle autotransplant. And oh, and this, I'll remind you also, with guidance from, again, Reed Nesbit, we were we're not famous for this, except if you look in 1980 Journal of Fertility and Sterility, you'll see we're the first people to do urologic endoscopy, and that's to identify the intra-abdominal testes. And actually, it wasn't, we had actually jerry-rig cystoscope to put in there. We didn't really have pediatric laparoscopes at the time. But you can see the testes like this is not a long loop testes. And so if you divide the spermatic vessels, this testicle for sure will shrink. And there's just, I'll just go through these quickly because I don't want to run out of time. And we would divide these testes. Now, we're not talking about a long loop testes, long loop vas, which is very simple with collateral circulation. We're talking about the extreme case where it's not long looped and you really don't have good collateral circulation at all. And we would divide them, reanastomose them to the inferior epigastric vessels, and bring the testes now conveniently into the scrotum. And there is just, you can see the inferior gastric vessels being lined up. And there is an anastomosis of the very, very tiny spermatic artery to the inferior epigastric artery. And you see, we had to spatulate, actually, the spermatic artery because it is so tiny compared to the inferior epigastric. But using that spatulation technique, we were able to get a good anastomosis. And there he is, this same kid with his family 41 years later. But we also taught, while we were in Melbourne, they taught the Michigan technique of microsurgery to Ian Taylor. And if you talk to any of your plastic surgery colleagues now, they'll tell you Ian Taylor is the god of plastic surgery with groin flaps and with bone flaps doing microsurgical reconnections. He was an anatomic master, but he came to us to teach him how to do the microsurgical anastomosis that Jimmy Crudup at the University of Michigan originally taught me how to do. And I practiced with him in Melbourne, and now he's world famous for doing free skin flaps and free bone flaps. He's the master of it all. And there's a picture of us doing the first clinical case, and he had me do the anastomosis. Of course, now he does the anastomosis, but he did all the magnificent, incredible surgeries, 12-hour operation to get ready, but I was lucky enough to do the anastomosis. And his sign there says, "Hey, Sherman, chalking up our first." That was in 1974, I believe. So this was our paper that led to that, transplantation of a human testis for anorchia. So we actually had a patient who was born with no testes, and his identical twin brother had 2 normal testicles. And they didn't want to do donor sperm insemination, and they had agreed they wanted to have 1 testicle transplanted from one twin to the other. And we got approval for this, presented at the AUA, and again, I got first prize for this video. Now, I always show this slide. I make a joke about it, but it's true. Can you tell from the husband and the wife's hair which of these 4 people is the testicle donor? Well, you're supposed to laugh when I said that because I think you're pretty obvious after the fact who was the donor. But at any rate, they were a happy together family.
Through the right groin of the recipient. Now we go to the donor and prepare the donor testicle for removal. You can see the donor was born with 2 perfectly normal testicles, and we are going to take out his right testicle through a groin incision for anastomosis to his twin brother.
For most of the men in the room, that's kind of an ouch. But anyway, it turned out beautifully. This is the recipient with a completely normal testicle. This is the arteriogram demonstrating beautiful blood flow via the inferior epigastric to the transplanted testicle. But then I finally, just only about 3 years ago, wrote a book, Fundamentals of Male Infertility, because all this took me to more classical male infertility. And I found that using this microsurgery, which was difficult vascular surgery, we could do the much more easy vasectomy reversal microscopically and suddenly have fantastic success. And we had no internet then. This was in 1975, but it made front page of the New York Times when I presented this at the American College of Surgeons meeting. And before you knew it, I was inundated with patients from all over the world coming in for vasectomy reversal. And though at that time I was a urologist that was a kidney transplanter, suddenly I was forced at University of California, San Francisco, where I was chief of urology at the VA and assistant chairman of the department at UCSF at the young age of 32, I was suddenly forced to turn all my practice really into male infertility. And so we developed not just vasectomy reversal from vasovasostomy. I was telling Ganesh earlier today that nowadays the vas is being so sealed, so carefully sealed by urologists that there's a high pressure buildup. And so most of your vasovasostomies will fail nowadays, even though they didn't fail 15 years ago, because the pressure buildup causes secondary epididymal blockage. And then you have to do the more difficult operation of vasoepididymostomy. So we developed a specific endoside, specific tubule vasoepididymostomy, and you can see these pictures. It works very well, but you really can't do the old-fashioned fistula. You have to specifically anastomose the vas lumen to the intercanal of the vas. But many of these failed, and they were men with congenital absence of the vas, and so what we had to do next was develop IVF, ICSI, and sperm retrieval. And we were the first to do that also. And that was, the first sperm retrieval was in 1986, but we added ICSI to it in 1992. And that would mean we would simply inject the sperm into the egg, because if you use retrieved sperm from either the testes or the epididymis, fertilization rate was extremely low. Results were terrible unless you combined it with ICSI. So we took all our patients to Belgium, where they were doing the original work on this, and I worked together with the Belgians, and we developed the whole sperm retrieval in ICSI, MESA and TESA. And so obstructive azoospermia means that instead of vasectomy reversal, at least we can now get all these wives pregnant. The sperm is never a problem, because if the vasectomy reversal fails, you can always do ICSI with sperm retrieval. And we learned something interesting, that if you take the sperm from the lower epididymis, where you think it's more mature, the sperm quality will be terrible, because they are old sperm that are senescent. But then, and you can see on DNA sperm fragmentation, we never did this with the COMET assay. We always did this with electron microscopy. And that was back in 1978. We published all the first papers on sperm DNA fragmentation, but with direct visualization of it. But that's what it looks like with distal sperm. And it's just, sperm fragmentation is just a matter of senescence. And there's always going to be a certain number of senescent sperm in every ejaculate. But then if you go to the proximal epididymis, you find that there's no DNA fragmentation. And using ICSI, your best sperm is from the proximal epididymis or the testes. Now, but non-obstructive azoospermia is a different story. There are men that you feel are making no sperm, but 60% of them are making sperm, but a very tiny amount, not sufficient to spill over into the ejaculate. So our paper in 1977 on quantitative analysis of testis biopsy was for non-obstructive azoospermia, and we didn't realize at first. We were trying to just see if you could predict sperm count by counting the number of spermatids in the testes. But what we found is when there was azoospermia, in 60% of the cases, if you look at this, you will see that there are some sperm in that testes, but too few to spill over into the ejaculate. So when we do test it, we sample every anatomic lobule, and you can see next to a sea of Sertoli cell only, you have occasional tubules with normal spermatogenesis. And then we pick up that sperm from the testes, and we do the ICSI. And even with Klein, we have successful cases. 80% of our Klinefelter's patients have some sperm on TESA, and we have a normal success. I just got a call yesterday while I was getting to the plane, coming here, from a 98-year-old rabbi who was my Hebrew school teacher when I was just 10 or 11 years old, thanking me because the TESA that I did on his Klinefelter's grandson 15 years ago and froze the sperm finally resulted in his grandson's wife now having a pregnancy in her 4th month, and he was so thrilled. And that was ironic that that occurred just on the way here when I was going to tell you about that. And you see, you close it up microsurgically, and there's no damage to the testes. I will say very, very openly that you must avoid, I'm going to make enemies here. You must avoid the Schlegel microdissection procedure. It just destroys testicles. What you have to do microsurgically is stay on the outside and not destroy the testicle by dissecting inside. And then if there's any spermatogenic stem cells anywhere in that testes, and I'll go back to even show you why anatomically. Yeah, if there's any spermatogenic stem cell in any of those tubules, they all loop to the outside and back again, and there will always be sperm on the periphery. And that way you don't damage the testes, and you'll find sperm. And this is an XY-XO Turner's mosaic, just like the Klinefelter's. Again, you'll find an occasional tubule that is completely normal. And they're tiny testes, and if you close them up microsurgically, you won't hurt them any. So what about male infertility in the Y chromosome? I mean, for a long time, it was thought that there were millions of different causes of male infertility. But really what we found out is that the sperm count is controlled genetically. Every man's sperm count, with a few exceptions, cryptorchid, or if they've had diseases, mumps or whatever, almost all your cases are going to be the sperm count is genetically controlled, except it varies much. And the reason it varies is not because of daily sperm production, which is genetic and constant. It varies because of variation in sperm transport when they're collecting their specimen. So what we found was there's a normal appearing, you have a completely normal appearing karyotype, But if you look molecularly at that normal appearing karyotype, we were the first to discover this AZFC region, or called AZF originally, where it's not small. I mean, it's like 180,000 base pairs of DNA that are blocked out, and they contain the DAS gene. And we found that we compared this with offspring from ICSI, because these men usually had occasional sperm in their testes, which we could get with Tessa. And then we looked at their offspring. The fathers had no sperm in the ejaculate, just an occasional sperm in their testes. And we looked at the offspring, and the offspring had exactly the same Y deletion. And so they knew ahead of time that their young men, when they grow up, are going to have to undergo Tessa ICSI also. So, and this is a more complicated map we drew of it. I don't want to waste too much time with it. We worked out the whole evolution of the X and the Y chromosome, and we were able to figure this out, why women can get along with two X chromosomes without having overdosage of genes that would be deleterious, and why men can get along with one X chromosome and be equally intelligent to women, because you would think with all these intelligence genes on the X chromosome, men would definitely be inferior. And maybe we are, but we're close to the women at least because of X inactivation, which we discovered by doing this work on the Y chromosome. And this is just a graph that shows that this could be a growth industry, because if all these men with, you can do the math, it's like a simple compound interest problem. If all these men with azoospermia were able to father children because of Tessa and ICSI, then we figured out in 10,000 years, the entire population of men would be azoospermic. And so this is really a growth industry. Now, we also found out with Turner syndrome, exo-Turners, girls, it is not because they're missing an X chromosome. They're not girls that are missing an X chromosome. They are little boys who are missing a Y chromosome. And so these are normal girls, except they're short stature and they're infertile, but basically they started out as boys. The XO is not the absence of an X chromosome in a baby girl, but rather the absence of a Y chromosome in a baby boy, because there's no maternal age effect in exo-Turner syndrome. And in 3/4 of exo girls, the X chromosome is clearly of maternal origin, which means she's missing a Y. So now the next final case of development, all from working with Jack Lapides and Reed Nesbit and Jimmy Crudup, is what we're doing now, IVM and in vitro gametogenesis. And I have too many slides here, but that's okay, because I want to stick with time and not bore people. But this is called the CHOSE project, and we're applying from what we've done in mice now to humans. So this little summary shows you what you can do with the mouse. We can take skin cells from the tail of the mouse, incubate them with 4 genes and make them into stem cells. And then those stem cells, and Yamanaka got the Nobel Prize for this about 10 years ago. So it's easy to do. And then we can incubate those stem cells with different gene transcripts, so we actually, in the mouse, get normal eggs. And so we have baby mice who were born from mothers who had no ovaries, whose ovaries were removed, born from their mother's skin cells. So this is what we want to do with the CHOSE project, which is funded by these people here at UCLA, and we have a collaboration with their stem cell program, was to do this for humans as well. And that's Katsuhiko Hayashi, who originally did this in mice and will get the Nobel Prize in a year now. And that's his chief assistant, Nori Hikabe, who wrote the first paper on this. There's Amanda Clark, who's doing the work on the humans with us. And there's Kyle Orwig, who is doing the work on the male, because we can also make sperm from skin cells. It's just more difficult than making eggs. And this is the group of us together at the UCLA lab. And all this material, human material, came from us in St. Louis. So in the mouse, we first make iPS cells from stem skin cells in the mouse's tail. And then we can convert those into PGCs, that's primordial germ cells. And those PGCs can either be converted into sperm in the mouse to make babies, to make good mouse, baby mice, or we can convert these stem cells to eggs and therefore make mouse pups from the eggs, all coming from skin cells. So now we wanted to apply this to human, and we wanted to see if we can make human PGCs. And we have made human PGCs now, we published it. But you need to incubate those PGCs in fetal granulosa cells to go to the final step of making eggs, or with Sertoli cells to go to the final step of making sperm. And I'll just show you, we take the biopsy from all over, these are old women. These are women in their 50s or premature ovarian failure, or just plain, frankly, postmenopausal women. And we did this with identical twins that were discordant for ovarian failure. This is a fantastic study. And we were able to grow normal germ cells, PGCs, from the skin biopsies of women who were born with no eggs, and of older women as old as 55 years old making normal PGCs, which means there's no genetic cause for them not to have eggs. It has to be a matter of germ cell misallocation in the embryo, which is important for this reason. We were finally able to determine by looking at their obstetric history, answering our question, when does germ cell specification occur in the early human embryo? Because very early in the embryo, there has to be a specification of cells that are set aside, that are not going to differentiate, and they stay in the yolk sac. They're not in the embryo, and they don't travel to the embryo until 3 weeks later. And we were able to look at their placenta reports from their original obstetric history and figure out that it was always late splitting monochorionic, monoamniotic twins, which means that since they have the normal genetic component, the reason for those twins without eggs having no eggs is simply misallocation of germ cells. And if you know when they split, which we do, now we can determine in the human, we have determined that PGC determination occurs in the early embryo at 9 days. And this is just to show you we were able to report normal human germ cells developed from skin cells in 55-year-old women. So in the future, a 38-year-old woman who might be better off, who's having IVF, might be better off having a skin biopsy than an oocyte retrieval for IVF, because these oocytes are generated in vitro from iPS cells in reproducing, reiterating the fetal process. So they're extremely young and very fertile germ cells. So I have many, many more that I could go to. I purposely put more than I could handle on there because I want to just give you an idea. I'm done with my talk. I just wanted to give you an idea that starting from great teachers like we had at the University of Michigan, you can't predict where you're going to go and what kind of progress is going to occur. Thank you.
And I'll introduce our next speaker. I'm very proud to know him. Dr. Diokno is the former chair of urology at Beaumont Royal Oak, now Corewell Health. I've had the pleasure of working with him. I've always heard many, many stories, and last year in 2019, you gave a great review of his experience with Dr. Lapidis. So let's go ahead and welcome Dr. Diokno. Thank you.
Well, thank you, everybody, and it's always nice to be back to Ann Arbor, where my family lived here for over 50 years since we started at the University of Michigan in 1968, and prior to that was at Wayne County area for the first 2 years. When media asked me to continue my talk regarding my life and times with Jack Lapidis, I decided to just extend my experience with him, although it ended up with how his life ended during my time. But then I started to learn more about this new topic that I became very interested during the COVID times. And when I keep asking myself, why am I not taught about andrology and about testosterone? And why is it that I have never prescribed testosterone during my urological residency? And why is it that I've always been referring my patients to endocrinologists? And the answer is because we do not think that testosterone is good to have for men because it can cause prostate cancer, it can cause BPH because of the 82-year dogma about Charles Huggins, wherein testosterone is the culprit that causes prostate cancer to grow and cause metastases and invade. So I started to read and learn more about it, and then I was surprised to see volumes of research about how testosterone is interacting with men's life. And therefore, I dig more into the basic science, and the more I dig, the more I am amazed with what I was discovering. And so I published a paper about a review about testosterone, its roles in man. And so I've been championing that the last couple of years, and I thought it would be good to share with you and challenge your thinking about your attitude towards testosterone. But before that, I know that some of you are still wanting to know more about Jack Lapidus and how I got to know him during my lifetime as well. So it started when I was a medical student at the University of Santo Tomas in Manila, Philippines, for which I was one of the 12 that were selected to intern at Clark Air Force Base Hospital in Angeles City, excuse me, in the Philippines. And I was lucky during that time that when I was a rotating intern, the first rotation was in urology, and I was met by three physicians. The first is Robert Ross, who was a general medical officer at that time, graduated at Wayne State and was going to go to urology. And then the two attendings were Dr. Joe Hart, who was trained at Stanford and who was the urologist assigned at Clark at that time. And then following him was Frank Leary, who happened to be trained at Mayo Clinic and became the chief at Clark. And the three of them guided me and introduced me to Jack Lapidus. And I suggested that the best way to go to be trained by him is to go to Wayne County General Hospital, which is a freestanding urological program, rather than going to the University of Michigan, where I will have no chance of being accepted there, being coming from the Philippines. So I was lucky. I matched with the internship program at Wayne County General Hospital. You heard about Wayne County from Dr. Hollander. And it's about 30 miles east from here, and this is the home of most of the county residents who are needing some help. But a lot of them are many buildings of psychiatric hospitals, and many of them are taken to the general hospital, which is right behind me. And it is at this time that I was lucky that the second rotation was in urology for 2 months. And after the first month, Jack Lapidus called me to his office and said, "I heard you wanted to be a urologist, and I happen to have a position available. There's one resident per year, and because of your previous experience at Wayne County General, at Clark Air Force Base in the Philippines, you can start as a first-year urology resident." And of course, there's no question that I accepted the position. And then when I became a first-year resident in urology, at that time, Tom Stone, and I think he has a son now who's a urologist, who I believe is also part of the University of Michigan from Muskegon. Jack became the chair of urology at the University of Michigan to succeed Dr. Nesbit. And so at that time, Jack decided to combine the Wayne County General Hospital program in urology with the University of Michigan. 3 from the University of Michigan, 1 from Wayne County, so it became 4 a year. And I became one of the 4 second-year resident in 1968. And at that time, there were 4 of us. One is to my left, second from the left is Tomohiko Kuyanagi, who a Japanese, who for the first time I met a Japanese because in the Philippines during my year the Japanese were not allowed in the country. So this is the first time that I was introduced to a Japanese, and I thought how wonderful this man is, who became a good friend. He became a chair of urology at the University of Hokkaido, and we have quite a few visits there. And he had visited here many times, and I was really disappointed that he was not here today. And then also John Hall, who is right at the second row at the middle. John unfortunately passed already. Rifat Dagger, who is a Lebanese surgeon who also was a much older gentleman, but is already a well-trained surgeon who decided to become a urologist. And then me, Tomohiko, John Hall, and Rifat Dagger. And you can see the faculty that Jack had assembled at that time. John Connock to the left, Joe Cerny, Carl Herwig, Ed Tank, and then Tom Costello. During my early years, so when I moved to University of Michigan, I was the first one assigned to the Jack Lapidus service. Everybody does not want to be assigned to him, and because I know him already before the Wayne County, I was the sacrificial lamb, so to speak, assigned to Jack. No one could really, they were so scared about him. And you heard from Jay Hollander that he is a matter of fact, no abbreviation. Start from A and work your way to Z. Always start with the age of the patient and the history and the past history, physical exam, etc., etc. If you miss one of those, you are dead. So the first thing he asked me is to review this stack of charts, 14 charts that I said, oh my God, this is so much. And so by that time, I have a handy person who is a first-year urology resident at that time, Sherman Silber. And so I asked Sherman to help me dig into these charts, and we reviewed all of that, and I guess we were amazed to see how good the results were. No significant amount of sepsis, no resistant symptomatic infections, improvement of renal functions, etc., etc. So this was ultimately published, and as you know, it became a classic paper in the urological circle. The amount of work that we have to do to pass the obstacle to go to the next level for its acceptance is unbelievable. From the nurses within the university hospital to the infectious disease people here at the University of Michigan, then to some of the urologists across the country. But fortunately, we have a pediatric urologist at Wayne State by the name of Alan Perlmutter, who embraced this immediately after seeing how good it is to see intermittent catheterization applied to kids with myelomeningocele, spina bifida, neurogenic bladder, and eliminate their incontinence quickly, eliminate the hydronephrosis, and eliminate all the diapers that that these parents have to use. And so he accepted it, and he was also helpful in getting this propagated throughout the United States and ultimately to the world. One day, he called me and he said, I have a bottle of this drug called oxybutynin that was taken from Mexico, and I would like you to try this and see if it's truly indeed this is going to be working for the bladder. Marion Laboratories think that it has a good anticholinergic, antispasmodic preparation, and why don't you see? And then they will do a randomized controlled trial if it works. So I said, what do you want me to do? I said, well, when you make rounds at the VA hospital, just give this patient one, ask them if they have urgency and frequency, and then give them a pill, and then you go back by lunchtime, you give them another one, and then you check the symptoms. So, well, we started doing that. And then after about 3 weeks, he called me and said, what do you think? I said, Dr. Lapidus, some of them went into retention. I said, great. So immediately called Marion Laboratories and said, we have a drug for you to do a randomized controlled trial with placebo controlled trial. So it was established. But before that, we have to try to figure out the duration of action. So he gave me another bottle of pills and said, go to Wayne County, and all of those men with the spinal cord injured patients, do a systometric before, and then every hour, give them one pill, and every hour you follow them out. And so I didn't think that we would give more than 4 hours. So I started about noon. I did systematic examination, see when the uninhibited contractions will start and how long it will last. And then we gave them every hour. And every hour I was going under the bed of this patient, trying to do the systometrogram. And then by midnight, I'm still doing it because the effect of anticholinergic is still going on. So it was more than 8 to 12 hours effect of the oxybutynin at that time. So we knew that the duration of action, because these uninhibited contractions before in a spinal cord injured patient, very reproducible. Within like 50 cc will go up. And on and on and on. And then when you start giving that after 1 hour of oxybutynin, it will be moved to the right and to the right and to the right until it's almost gone for a while. And then it will start coming back. So at least 8 to 12 hour duration. And so I have to do the systometrogram for almost 24 hours to prove the duration of this drug. And then ultimately we get a randomized controlled trial. And that was the first drug ever approved by the FDA for the management of uninhibited neurogenic bladder at that time, which is now called overactive bladder. Then he also asked me to help Tomohiko Kuyanagi for the cutaneous vesicostomy technique that he invented, and that also got published. As you can see, we ultimately have a 10-year survey of how good it is in minimizing, and that is where the concept of high intravesical pressure came up. That the culprit in causing problems in the upper tract is the high intravesical pressure that is causing the bladder to become very thick, causing obstruction at the intramural portion, or if they get reflux, it is the pressure that's going up into the kidney that ultimately lead to renal failure, staghorn calculus, and on and on and on. So either the bladder gets so thick and obstruction, or the reflux goes up. And so if you relieve the pressure, which then with the cutaneous vesicostomy or periodic, frequent, intermittent catheterization to prevent the bladder from getting high pressure and pushing bacteria out into the circulation or upstream to the kidney, you can prevent kidney problems, which actually is the reason why all of these patients get better with intermittent catheterization, with cutaneous vesicostomy, and by relaxing the bladder with anticholinergic agents. So all of these three tied up into one basic principle: high intravesical pressure, avoid it at all costs. After my residency, I was appointed as a fellow in neurourology and neurogenic bladder. And at that time, I decided to study the pelvic nerve and as well as the pudendal nerve and the correlation between the synergia and dysynergia. And during this particular time, here's a picture of class 1964. Now you can see who are the faculty standing in front. I think you see Bob Burnett all the way to the right, standing, and then Steve Koff and Evan Cass, the two pediatric urologists that many of you may have known and heard about. As a faculty member, which I progressed from instructor to assistant professor, associate professor, and ultimately in 1982, I became a full professor here. And my focus was then to apply the knowledge of the relationship of sphincter to the bladder, and then the different between coordination, discoordination, and different types of dysynergia. Dysynergia is not just one bladder contraction and the sphincter contracting, but there are also some of the clonic type. There's some where in the sphincter is just not relaxing, but the bladder is really not doing much. So there are many different categories, and you can study that by doing the combined cystometry and electromyography. And this exhibit, scientific exhibit, also won first prize award at the AUA and in many, many other exhibits that we have presented this particular paper. My second focus when, and one of the things that in academics is that don't sit in one particular topic and rehash that, because when everybody learns about it, then there's nothing more for you to speak about. So the next thing I thought was geriatric incontinence, and that's where I focused myself. And then I was able to connect with two geriatric nurses, one trained in London by the name of Thelma Wells, and one from Rochester, New York, by the name of Carol Brink. And the two of them helped me, and we worked together at the University of Michigan, and we started applying for NIH grant, and we started getting a few of those, and established the first continence clinic in the United States here at the Turner Clinic at the University of Michigan, which at that time just barely opened. Excuse me. So that led me to the development of the concept of how to study the whole picture of geriatric urinary incontinence. And one day, Jack Lapidus called me and said, there is a meeting at NIH, and that will be to discuss the future of geriatric urinary incontinence as part of the aging program. And here are the people who are going to attend. And I open my eyes and I say, oh my God, Sol Boyarsky. I was reading his book about who Dr. Boyarsky, which at that time is really the guru on neurogenic bladder. Dr. Williams, thank you. Dr. Williams, who became the head of NIA, we have Bill Bradley, which many of you may have read, the 4 loops of the connections between the brain and the bladder and so forth and so on. And Shlomo Ras was also there at this meeting. And Evan Hadley, who is now the director of geriatric incontinence at NIA. So at that meeting, they decided that they will be focusing geriatric incontinence to be funded by NIH. So as soon as I came to Ann Arbor, I told Jack that I am going to write a application for this particular project. And that was the birth of the MESA project, the medical, epidemiologic, and social aspects of aging. I was a little more ambitious. Rather than just submitting an R01, I decided to submit a program project. There's an epidemiology, there is pathophysiology, there's pharmacology, and there's surgical treatment. Wow, four projects in one, and this is called program project. And so I connected with the geriatrician, I connected with social scientists, I connected with epidemiologists, public health. So I learned a lot of experts in the University of Michigan, submitted this, and in one round, we were funded by NIH back in 1982, and this is maybe the first time ever that the section of urology and the Department of Surgery ever received an NIH funding, because when I talked with Jack about submitting this, he said, you don't need it, we have a lot of money, why do you need NIH funded grant? And I said, well, that is a little different than being funded by the university or funded by grateful patients. So that was the beginning of my 32 years of being funded by NIH almost continuously. And in 1997, I believe, I received the merit. 1989, I received the NIH Merit Award based on my work on geriatric urinary incontinence. And you can see from epidemiology to pathophysiology, we studied the urodynamics of older men and women who are normal, which I don't think that now you can do systematic and pressure flow studies of these elderly people. We also did from epidemiology to surgical pharmacology and ultimately to prevention of urinary incontinence. And we started switching into behavioral modification program, which ultimately was adopted by the guidelines. I was the co-director of the first ever guidelines on urinary incontinence in the elderly. Before Jack retired, Marion Laboratories honored him by establishing a Jack Lapidus International Neurology and Urodynamic Essay Contest. We're still going on at this time, and actually next year will be the 40th year anniversary. This is a picture of Barry Cogan, who many of you know is a pediatric urologist who is now also in the administration in Albany, and he was the recipient of the Jack Lapidus essay contest when he was still at the University of San Francisco as a pediatric fellow back in 1988. Unfortunately, we all know that life doesn't go on forever, and ultimately Jack passed away on November 14, 1995. It was a sad story because when he was retired and I was busy at the Beaumont, he had invited me many times to his house, and over a glass of Bordeaux wine, which is his favorite, he said, "Ananias, when I get sick and I cannot decide for myself, you will be my advocate." I said, "Oh, sure, no problem at all." And as we were talking, he also said that if I die, I want my body to be donated to the anatomy class of the University of Michigan so that they can learn and get something out of me. I almost fell off my chair. I said, "No, I don't think I would do that." I said, "Well, you won't, but I will." And so that was the last word that he gave me. And then one day I got called when I was in Hawaii giving a presentation because he had a massive stroke. And he was comatose at that time. And when I came in, we decided that we'll just support him, but not do any heroic attempt. And there's a lot of stories behind it because I did not realize that he has a sister whose temperament and whose aggressiveness is worse than Jack. And so question me about why he should not be cremated, and question me why his life is still being prolonged, and so forth and so on. But that's beyond the story. So anyway, he passed away, and then I realized that you have to go to a funeral home, and then from a funeral home you have to go back to the Department of Anatomy, and then after 6 months, the dissection was over and he was cremated, and so that is the end of the life of Jack Lapidus here from 1968 to 1995. 1984 as a chief of urology here, and then passed away in 1995. So now I'm going to go to my second topic that I have been championing, and I have never done any specific basic or clinical study on testosterone, except I spent almost a year doing a review of this particular topic. Just a brief background for all of you, and many of you, of course, know that the testosterone is produced by the pituitary, hypothalamic pituitary gonadal axis, that the testosterone is a very essential hormone for the development of the prostate during the embryogenic stage, for the maturation of the prostate during the pubertal stage when the testosterone is rising, and maintenance when it reaches the adult stage, which is approximately between 20 to 30 years of age. Then the prostate is mature, and all the testosterone does is to keep the prostate maintained for what it's supposed to do, which is to survive and to reproduce. So the prostate is part of the whole life direction for all of us, which is to how to learn and live and survive, and by survival is also to reproduce. That's basically all. You look at plants, you look at fish, you look at human beings, you look at animals, and that's basically what it's all about. Let me just go back to that again. Testosterone also needs cholesterol to synthesize, and vitamin B6 to synthesize testosterone. Also need, I made a mistake, there's an aromatase enzyme to convert testosterone to estradiol. As you know, we have enough estradiol in our men's body as well. And the 5-alpha reductase to convert the testosterone to dihydrotestosterone inside the cells. And testosterone is extremely important almost throughout our body, from central nervous system to heart, liver, kidney, sex organ, bone, skin, and skeletal muscle, and metabolic system, diabetes, weight control, and so forth and so on, lipid metabolism. This may be a little harsh word to say, but I concluded that there's worldwide epidemic in hypogonadism, and as a consequence, with prostate cancer. And the last one is my addition to that. But I think you look around, and the question is, you can see that from the age of 30 to 40, testosterone just dwindled down to almost nothing as we get older, when you get to be 80 and 90 and so forth. So you can see the downward trend of testosterone, and then you can see the upward trend of hypogonadism and the upward trend of prostatic carcinoma and BPH. We accept the fact that we will have BPH. We accept the fact that most old people will ultimately end up, you live old enough and you will develop prostate cancer. Why are we accepting this particular phenomena to be the case? Have we ever thought of why, and can we prevent this from happening? And so these are the thoughts that I have when I started reviewing this. The use of testosterone in men is discouraged because of the long-held Huggins dogma of over 80 years. Prostate cancer is dependent on androgen and testosterone, and deprivation causes prostate cancer to regress and involute. And that is why the basis for androgen deprivation therapy, which became standard for the management of advanced prostate cancer. We avoid the use of testosterone, not only because of overuse, but that is beside this topic. But testosterone is feared because it is supposed to be contributing to, if not the cause of age-related prostate gland diseases such as prostate cancer and BPH. And the guidelines oppose the use of testosterone by becoming very restrictive. They oppose the screening. Do you know what your testosterone level is? If you don't, when you go to your primary care, you better ask for one. There must be a level that is no more than 349 to be diagnosed to be hypogonad. And also you have to have 1 or 2 symptoms before you can be called hypogonadism. And without those, you cannot receive testosterone. The normal range of testosterone, unfortunately, is very wide. At the age of 19 to 39, it is 267 to 929, with the 50th percentile to be about 530. I call it my 550 nanograms per deciliter to be the normal amount. Unfortunately, because again, if your testosterone when you're 30 is 700 and it goes to 500 when you're 60, you cannot be called hypogonad, although you may have symptoms because the requirement is 345. This is the, look at the blue line, where in the testosterone highest level is the age of 30, and from then on it is downhill. The dotted line is the estradiol, and then the solid line is the testosterone. After 30 to 40, it is downhill, and I don't know of anybody without taking anything that it ever goes up after the age of 30 to 40. So if you're 40, 50, 60, 70, 80, it is all downhill. The review found that I have done over the 2 years ago, many compelling studies that low or declining level of testosterone and not high level that could initiate prostate tumorigenesis. And by prostate tumorigenesis, they all define this to be either development of benign or malignant tumor, even in the prostate gland. They reported the mechanism, again, all of this is from review, and I put my reference because there are about 15 or so, many references that support this, that the level of testosterone causes upregulation of the androgen receptors that bind the testosterone that could be available to enter the cell, and that this combination of androgen receptor and testosterone causes genomic, DNA, and cellular alterations that amplify oncogenes and delete tumor suppression genes. In the cellular level, there is data by Song and Kira, by Lee, and a few others now that show that the lower the level of testosterone, the faster the growth of prostate cancer in Petri dish. And the higher level of testosterone causes inhibition of the prostate cancer, the reverse of what you would expect. Also, it suppresses the transporter of zinc, and the low zinc in the prostate apparently is also a cause for tumorigenesis. And lastly, among the mutant mouse model, the P10, when you orchiectomize them and you put only a small amount of testosterone, the prostate grows faster, prostate cancer grows faster. If you give enough testosterone, they do not develop prostate cancer. So these are all evidences to that effect, so that the rapid decline of testosterone, according to many insurance data, suggests that the decline is a risk factor. The lower and the faster the decline, the higher the risk of developing prostate cancer among those, while those who have minimal decline have lesser incidence of prostate cancer. There are also a lot of papers suggesting that testosterone treatment for hypogonadism is safe and effective. And very recently, just last June, this NIH randomized controlled trial, the second line, showed that testosterone replacement therapy improves cardiometabolic function, does not cause heart attack, does not cause a stroke when given compared to those who did not have it. As a matter of fact, there are many data suggesting that those who have been on testosterone replacement therapy have less mortality, less morbidity than those who did not take that. There's also a lot of papers showing that testosterone is safe in patients with prostate cancer. The long-term use of testosterone does not increase the incidence of prostate cancer and so forth and so on. So I'm not belabored that point. There are also several pilot studies suggesting that using the BAT, the bipolar androgen therapy, which is a high dose of testosterone therapy, is feasible to be used as a potential trial for those who had failed androgen deprivation therapy. When there's no other choice, you may even as far as after Taxotere that you could use this high dose of testosterone. And as a matter of fact, there are now 5 clinical trials that are registered in the clinicaltrials.gov that is using the high dose testosterone in the treatment of advanced prostate cancer that had failed the androgen deprivation therapy. And one of the studies that is going on now is that it may be the MYC gene that may be causing, those prostate cancer cells may be responsive to high dose testosterone after they have failed androgen deprivation therapy. So I have been recommending, based on what I have read and what I have seen, and most of the complaint is that this is not a randomized controlled trial, which will take forever, is that I believe we should be more cognizant of the symptoms and signs of hypogonadism. We should try to relax the guidelines in diagnosing and treating hypogonadism, and that we should initiate therapy when there is signs of hypogonadism and try to maintain a level that when you were in your 40 years of age. There are endogenous therapy that are very effective and that you do not need to go to an andrologist to get a prescription of TRT. These are data that are buried within many of the publications, but I am very supportive of ashwagandha, vitamin Vitania somnifera, 1,000 milligram daily, and it has been shown with placebo-controlled trial that it increases the level of testosterone within the first 3 months of its use. Its effect starts at about 6 weeks and that by the end of 3 months. Also, it has to be supported with the synthesis of testosterone with vitamin D3 and pyridoxine. And lastly, there is also a supplement called grapeseed extract that inhibits aromatase so that it prevents the conversion of testosterone to estrogen and therefore preserve more testosterone. So ashwagandha, vitamin D3, pyridoxine B6, and grapeseed extract will enhance the testosterone, but they're also an anti-inflammatory agents. I believe that we should not eliminate the use of testosterone for those who have hypogonadism but do have some risk for prostate cancer. There's so many data, but then, of course, this has to be discussed with the patients themselves. And in conclusion, I believe that declining level of testosterone is not only associated with hypogonadism, but to prostate cancer and BPH with LUTS. There are data suggesting that testosterone can improve the symptoms of LUTS. Replacement therapy is effective for treating hypogonadism even in patients with prostate cancer and BPH, and diligent monitoring and declining testosterone could enable disease prevention, and we encourage more studies in this particular regards. Thank you.
And next we have Courtney Streur, who's one of our pediatric urologists, who's going to talk about something that I know strikes fear in my heart, which is when a pediatric patient comes to your office and they're now an adult.
So thank you very much for this opportunity. I knew since I saw the schedule that this would be a very hard act to follow. So thank you so much for your excellent talk. So we're going to talk about a topic today that brings fear to most people's hearts. And I'm going to give this talk from the specific lens of your patients with spina bifida, also relevant for people with cerebral palsy. So to give you a little overview of what we're going to be talking about today, first I'm going to set the stage, understanding the problem, and then I'm going to give you kind of a framework that I have learned to use at working with these patients and doing research to kind of get at what is really going on. And then I'll tell you a little bit about our transition clinic. So to set the stage, as an adult provider, this is what you like to walk into the room and see: your patient. Nothing brings more fear to your heart than seeing your patient's mom. Even worse if they come with both parents, or if there's some random third person in the room and you're spending your whole time trying to figure out the relationships. So many thoughts probably go through your mind. Who am I supposed to be talking to? Please tell me they didn't have any crazy surgeries by Dr. Park. Please tell me they don't have any kidney stones in their augmented bladder. What in the world do I do with these parents? Please tell me these parents aren't the kind that are going to call me every day, and so on. And what's the problem? So there's guidelines to tell you how to take care of these patients. The Spina Bifida Association, if you go to their website, you can download their guidelines. They also have an app. It's really straightforward. You get renal bladder ultrasounds, maybe some labs, think about cystos, all easy peasy for us as urologists. You do have to think about their sexual health as well as their reproductive health if they're interested. Many are living long enough to think about prostate cancer screening. And the same goes for women. You should also be addressing their sexual and reproductive health. But it's all there on guidelines. So why is it hard? We all know it is, and I can give you an example from just earlier this week. I had a 19-year-old patient come to the emergency room. It's been 2 years since they've gotten any care, had really complex reconstructive surgery somewhere else many years ago. Come in, they can't cath their mitrophin off, they have some nice bladder stones, a UTI, they have a Chait tube that hasn't been changed in years. Used to work great, but it's hurting and they can't use it anymore. And now they're in the emergency room. So we know this isn't unusual. There's tends to be a time gap between when a patient was seen in the peds clinic and when they show up in the adult clinic. Often they really actually show up in the emergency room with some sort of an acute issue. And usually they're not quite doing what it is that we hope they're doing as urologists. But why does this happen? What exactly is going on? So as I think about this and address my patients, I've learned a lot from a psychologist out of University of Chicago, who I'll talk about some of his work, but Grayson Holmbeck, who proposed this model for understanding spina bifida patients called the bio-neuropsychosocial model. I've modified it a little bit. I think we have to think about systems and society factors that are also at play. And I'm going to explain it here. So the biologic stuff, that's the stuff that we get. So the things that they have going on in this late adolescent, early adult phase, pretty straightforward. Not usually the biggest issue. But what else is going on? So neurologically, this is a time when a lot of them start experiencing neuropathic pain, getting chronic back pain, often leading to a decrease in their mobility. Many of these patients also have some sleep disturbances that they maybe have always had, but is coming more apparent at this time. Psychologically, it is very common, nearly universal for these patients to experience depression and anxiety at this time period, which can directly impact their medical compliance. And then we really have to think a lot about their neuropsychologic functioning. So most of these patients have some level of executive functioning limitation. And what does that mean? So that's your ability to plan, to process, to adapt to change, like the administrative assistant of your brain, your ability to organize. And so the way I like to think about it is that you can teach a patient how to catheterize at home. That does not mean they can catheterize at school or at a friend's house. It also means that if something comes up, their bladder starts going crazy because they're constipated and they're leaking more, they can't necessarily adapt to that change, or they struggle with that. It also means that if they become emotional, they will shut down. So if you're on a visit with them and they're nervous with their first visit and become emotional, you might as well stop what you're saying right there and schedule a video visit or another visit later. They often have issues with numeracy. And so if you tell them you need a cath one more time a day, worthless. You need to either sit with them or have their parents sit with them and figure out like at what point of the day they're actually going to cath. I had a patient had a great idea where they put 5 bracelets on one side of their arm at the beginning of the day. Every time they cath, they move it to the other arm. And that was a way that they could remember. Some people also have attention problems, slow cognitive processing, which is exactly what it sounds like. And many also, like it takes them a while to process language and come up with a verbal response, which you have probably seen in some of your patients, which can greatly impact their social function as well. And some of them may have like very great superficial conversations with you, and they can really fool you as to their cognitive function, because if you try to talk about more complex things, they may struggle. And we don't really know how much of this is really related to like sleep problems. They often experience difficulties with peer relations, especially if they have neuropsychologic functioning issues, which independently is a risk factor for depression, anxiety, and loneliness. And certainly we know that the family impacts a lot of things. So I'm going to give you some brief summaries of Grayson Holmbeck's work. So he, again, is a psychologist out of University of Chicago, and he's done some really incredible work. He recruited some patients in early childhood, and then he evaluates those patients as well as their families, peers, and teachers every 2 years through various psychometric tests and direct observations. And so he's really helped us understand kind of what their normal trajectory is. And as you can see here, the higher the number is on the y-axis, the more independent the person is with medical self-management. And as you can see here, their independence or their growth towards independence doesn't stop at 18. So you can see it continues to increase between age 18 and 28, more so for men than it is for women. And this is just kind of breaking down the various elements of medical management, but it continues to improve with time. Specific to cathing, again, it continues to improve through adolescence and young adulthood. Although there are some people, as we all know, who never have any kind of improvement. Those are probably the people with cognitive problems. And the same thing goes with social skills. It takes them a while to develop social skills, although unfortunately they do tend to lag greatly behind their peers with companionship. So the people with spina bifida are in that black line, the solid line, and then their peers are at the dotted line. And so to really understand like what's going on here, I'm going to explain to you some results that we've done with some qualitative work. 2 studies here. One is interviewing parents of adolescents to get their perspective on the social development of their child during adolescence. And the other is some interviews that we've done of college students with physical disabilities. It's going to sound a little doom and gloom because the goal today is to tell you the problems they may face. If you want the more comprehensive understanding, please read our papers. So I'm going to give you examples for kind of patients and the issues that they may face. So the first example I'm going to give you is someone who has a physical disability and also a significant cognitive disability. Going through adolescence, they start separating a lot, or their peers start separating a lot from them. I'm going to let you read this quote for the sake of time, but that can be really hard for them socially. Additionally, they don't tend to get the same ability to have one-on-one time with peers without a lot of parental oversight, which is needed for normal social development to learn your social skills, which can be a problem. And then in the state of Michigan, there's a young adult program. That means they can basically go to school until age 26, which is great because at school they get that social interaction. There's someone who can help with cathing or medical stuff. But at age 26, it just stops. And so after age 26, they no longer get that social interaction. And for the families, like if anyone works, they no longer have someone to help watch their son or daughter. And there's no one else to, we all have patients that we know only get cathed while they're at school. And so they no longer have that support. The second example I'm going to give you is someone who has significant social problems. And one thing I have come to understand is that we may be to blame for some of the social problems that they experience, especially if they have, if they have to do a lot of bladder management. That may limit what they feel comfortable doing socially and how much they feel comfortable leaving their house. And then medical trauma can directly impact their anxiety. And so for these people, sometimes that social anxiety will greatly limit their independence, even if they're capable of being more independent. So the next example patient I'm going to give you is someone who has a physical disability but is very social, but maybe needs some assistance. So these people also often struggle during adolescence because they suddenly become much more aware of the differences that they have compared to their peers. And additionally, once school is out, again, they miss that regular social interaction. And many of the times they have a hard time keeping up with their peers who are kind of off doing other things that they are not able to do. And then going to college, I always thought that would be easy and I should really be pushing my patients to go to college. But the reality is that we have great supports in high school for people with disabilities. They can get parapros, they can get cath, they can get all kinds of help. That does not exist in college. And so if you go to college, you have to somehow find a way to get supports if you're someone who needs help in the bathroom or anything like that. And that only becomes worse as they try to do an internship and then go out and find a job in the real world if they need some supports for things like bathroom help. In terms of actually finding a job, which I always encourage people to do, it's hard. There's no doubt that there's a lot of bias in the workplace and for hiring, and it's really hard for people with disabilities even to get there. You have to put it on your application. So even to get in the door, to get an interview can be really difficult. And then say you get hired. Most employers, as well as probably for all of us, we don't truly understand what it may be going on and how to best support people, the number of sick days that they need for an illness, or if they are running late because their bowels went crazy that morning, or that kind of stuff. We tend to not be supportive enough or understanding enough. And then if they need disability coverage, we make it really hard for them to work. So you have to pretty much get an exception, especially, and you have to get paid. You have to work less than a certain amount and get paid less than a certain amount, even to work, if you're someone who needs the support of disability coverage. And then if you have a regular job with regular insurance, it usually does not cover everything that you need. There can be some difficulty finding romantic partners, but there's plenty of opportunity. But if you have disability coverage, you can't get married or you lose it. So then the last example that I'm going to give you is someone who has no visible signs of a physical disability. So we have plenty of spina bifida patients who fit into this. And I used to think that they had it made. But what I've discovered talking to patients and parents is that they feel like everyone sees their disability. And that can make it hard to relate to peers. They also struggle because people may not see their disability and they have no idea how much they work and how much they have to do or what they face. And then two, when my patients say oh, I have a bladder leak or a bowel leak once a month or something like that, I'm like, great. But I don't really think of the impact that has. This mom talked about her daughter who won't date because she has occasional bowel leakage at night and would be mortified if she had a romantic partner. They have similar concerns going to college. The bathrooms we've realized are a big concern for these people, people with disabilities going to college, wanting a private bathroom for obvious reasons, as well as going on to finding an accommodating job. Because again, if they have some like bowel leakage in the morning, that's going to take, they may be late. I in fact have a patient who wants to be an engineer or a doctor. You would have no idea that she has a disability just by talking to her. And she's rethinking that because there's some mornings that she runs late for similar reasons. And then once you become adult and you're out of children's special services, you can't get like the Navina or the Peristeen anymore. It's hard to get referrals to people like psychologists or neuropsychologists. And then we talked about the disability coverage. So in summary, caring for transition patients is difficult, but it usually has a lot more to do, or there's a lot more going on than what we can just see on urodynamics. And so for us as pediatric providers, I think it's important to think about like ordering everything that we can before they turn 18 and maybe giving our adult providers a little social history. And then for adult providers, just remember the whole family and think about everything else going on. And just a quick note, we do have a transition clinic. I'm happy to see any of your transition patients so you don't have to deal with this. We have 2 of us as urologists, a PM&R physician, as well as an adolescent gynecologist. So thanks for everyone for supporting that. That's it. Thanks.
All right, next we have up is Dr. Gupta, who's gonna tell us a little bit about global health in 2023. She's also our new program director starting this year.
Yeah. Great. Thank you. Okay. Hello, everyone. Well, thank you for having me. You get to hear me talk for a little bit this afternoon. So this first talk I'm going to give is just about a topic that's really near and dear to me, but I'm also really excited for what global health can look like for our department going forward. So I think one of the questions, I think the definition of global health has really been changing over the last several years, and we're really starting to get outside of just thinking about going abroad and providing care, but really what does that mean? And there's so many factors, economics, sustainability, engineering, all these other public health factors that play a role in what we're doing in the medical care that we provide. So I just want to put this up there to frame this. And I'm going to frame what we discussed through 2 initiatives I've been part of. So I kind of am going to start by talking a little bit about my journey into global health. So I became a urologist primarily because I was actually interested in obstetric fistula, and that was something I was exposed to very early on in medical school. And when I became a resident, I was like, gosh, I'm really interested in this problem, but what can I do? I'm a second-year resident. I don't really know how to do anything. I barely am learning how to operate. So if I go abroad, where can I be useful? What is my role? And so I was really fortunate at University of Minnesota to find mentors who encouraged me to think about global health from a capacity building standpoint rather than me going and doing surgery. And so I ended up finding out about, the Federation of International Gynecologists had just put out a curriculum for training people in obstetric fistula. And the idea was to have a standardized curriculum so that when learners go to a place, we're assessing competency and saying, yes, you're competent to be a fistula surgeon. But they created this kind of very large manual. And interestingly, there are no pictures. There's no description of how to do the surgery, but just lots of paragraphs about what competency should look like. So that's kind of where we entered. And one of my mentors at University of Minnesota had done a lot of work on surgical simulation software and actually started a company called Red Llama. The platform was based on trying to do competency-based education, kind of creating a cognitive trainer. So assuming someone could at least operate, throw a suture, but how do you teach them the steps of an operation? And so that was kind of the platform. I also got involved with 2 other organizations. One is a colleague of mine who's been working in Senegal and started an initiative. It's American Senegalese surgeons teaching surgeons. So ASSIST, it's a nice long name. But really the idea was, again, this collaboration between 2 groups working together and learning from each other. And then Children's Surgery International, they've done a lot of work on cleft palate. And so actually out of all of this, when I was a resident, I started a nonprofit called Medical Simulation International with a couple of colleagues, again, just focused on this idea of how do we use simulation software in low and middle income countries. So my first trip was to Senegal as a second-year resident. And for the residents, all of my trips I took were actually during my vacation when I was a resident. So I did not have protected time for this. But I went to Senegal. And during the first phase, we said, well, if we're going to teach this surgery, we want actual video of fistula surgery being done by the expert surgeons in Africa, not us. We're not the experts. So I went, Dr. Seringue, who's pictured here, was designated as one of the fistula surgeons. He was actually here a few years ago. I took some high definition endoscopic cameras and I took videos of his surgeries. And what was really fascinating about this is he has a number of trainees from all over Western Africa that come to learn from him. And most of the time you've got like 5 people behind trying to observe vaginal surgery and no one can see anything except for the surgeon. But when we had this camera in the room, just even having that, all of a sudden everyone could see what he was doing. And just through that, we were starting to expand what people were being able to learn. So we recorded a number of fistula surgeries and then came back home, looked at the video, realized we didn't have everything we needed. So I ended up taking some additional trips, went to Tanzania. I also spent some time in Ethiopia. And during these trips, we again kind of went with master fistula surgeons. So this is at the Hamlin Fistula Hospital in Ethiopia. Dr. Andrew Browning is operating. He's spent many years doing fistula surgery in Tanzania and Ethiopia. And I want to highlight the woman who's assisting. So her name is Mamitu, and the Hamlin Fistula Hospital is, we're going to talk a little bit more about it, but a really incredibly special place. So she herself was a fistula patient that Dr. Catherine Hamlin treated many years ago. They recognized kind of that she was, really intelligent, really bright. She started helping out in the operating room, and she's now actually a foremost fistula surgeon herself. So, really kind of a model of how we can empower patients to also learn and, develop their skills. And so Dr. Hamlin, she passed away a few years ago, but her and her husband had been in Ethiopia for basically their whole life. And they created the Addis Ababa Fistula Hospital. And this place is really a very beautiful and special place. They really provide comprehensive fistula care. They have expanded thinking about how do we prevent fistula, so that they have a midwifery program. They've helped train many midwives and help improve access to cesarean section, preventative measures for fistula. They've also trained many patients to be physical therapists, to be nurses, to be assistants. And then they also provide literacy education. So, again, the complex of this disease is that these patients are ostracized from their homes. And so if you fix them surgically, how do they go back to their communities? Many of their families have already kicked them out, and this program has thought about, let's train these patients, give them skills so that they can go back to their communities and they can start businesses and be, reintegrated. So it's really kind of an amazing place. The other woman featured, there's a fistula patient here, and then the other woman also was a patient herself and then trained to be a physical therapist. So, really a beautiful place. But I think it also highlights the model that we need to be thinking about when we think about the care of these types of patients, is that it's not just about the surgical correction, but it's about the whole disease process and how do we impact that. So, I faced several challenges when I tried to create this program. There's differences in surgical technique. So we were trying to find consensus. How do we optimally teach fistula surgery? What is competency? How do we get the right cases? How do we show people the right cases? How do we get high-tech video equipment to Africa? I had things get lost many times. So, there's lots of barriers. You have a great idea, but there are barriers when you're trying to transport this and kind of bring these ideas in a different setting. And then I think there's some other cultural questions to ask ourselves, who do you feature in a trainer? And so we asked ourselves that, and we said, we want to feature the surgeons doing this work. It shouldn't be me. I'm not an expert. So, we really featured the prominent fistula surgeons of that time. Is our curriculum culturally sensitive? Are we addressing the issues that are actually facing the patients that are in these communities, or are we addressing them in a way that is more, westernized? So I think these are all features we want to think about. And then is our platform appropriate for the audience that we're trying to reach? So let me show you what our platform looks like. And what's great about this trainer is that you don't need the internet. So again, many of the places that we're trying to transport this curriculum to, internet can be spotty sometimes. So this is something you can just run on your computer. And it's a program that actually contains live video. You get to choose a surgical instrument. You interact with the video, so it'll ask you at various points in the surgery to pick your next step. If you're right and you click on the right area, the video progresses. If you're wrong, it stops until you kind of figure out what you need to do. So the program really walks you through sort of the basic steps of a surgery. We also included, several lectures, several reference materials. So it's really kind of I would think of it as like a live surgery textbook, that is something that anyone can use. So I was really proud of this. I created this. It kind of took me all through residency and fellowship to finish this project. And then it was the next phase, which is how do we get this out? How do we get people to use it? And then I encountered lots of barriers. So, COVID was a challenge. And I think really a big part is you need a local champion. So we have this great platform, but who do I get? I'm not there all the time. So who do I get to really help get this out to trainees locally? And then how can I measure if it's effective? So, we had a number of different times that we tried to do this with different cohorts of residents and trainees. And it certainly had some adoption, but we've had a lot of challenges. People leave hospitals, they go other places, and then your project sort of falls along the way. And so really the next phase for me about this is re-engaging, and kind of the next initiative we're going to talk about has been an opportunity to look at really getting this out to people who are doing fistula surgery. And then also kind of working with some new collaborations to see how we can use this. So I'm going to talk about a recent trip I took. So Dr. Stephanie Kilb's here in the audience, and she and I went to Rwanda in May, and she's been part of an organization called IOWD. So here's Rwanda for the map, kind of some perspective of where we went. And it's the International Organization for Women in Development. And so Dr. Keel's been going there for many years, and she was kind enough to invite me to join her this year. And I was able to take our second year FPMRS fellow. And what IOWD's done, and I think again is a nice model for thinking about how we are doing global health, is that they've really thought about really the whole surgical process and how do we do safe surgery when we're abroad, and how do we educate patients, how do we ensure that we're following all the same steps that we would follow at home in another setting. So this is kind of their principles of their process, really explaining the procedure and the exam, educating patients about their care, the anesthesia staff really taking time to explain to patients what's going to happen, what they should expect with their anesthetic. Then safe surgery, so instrument counts, timeouts, those are things that IOWD has really instituted and kind of brought over in terms of thinking about safe surgery. And then providing instruction for both the medical students and providers, but also the nursing staff that are there, and helping provide the pre and post-operative care. So I think, when I joined on this trip in May, both our second year fellow Patricia and I really had a chance to see, again, another model of care, and one that's been very successful in helping to translate these concepts of safe surgery and also help involve local surgeons in getting trained in these procedures. So I think some of the value that comes for us is us going abroad and thinking about how we provide care is thinking about the differences in diagnostics and clinical care. So I put this picture up here because this was sort of our exam room setup. And, we didn't have a lot. So you're trying to diagnose a fistula. You don't have imaging. You have to really think about listening to the history of your patient. So really asking the questions, when are they leaking? Thinking about doing those double dye tests that I ask the residents about all the time during lectures. We actually did all of those. And we have to clean our own equipment. So we use the same speculums. We're not using a new speculum for every patient. We're sterilizing them in between each visit. So thinking about that process. And I think one of the education points I hope that global health experiences for our residents are going to do is show us you can do a lot with much less than we use here, and we waste a lot. And there are so many ways that we could be really thinking about our environmental impact as well. So this is another part of the mission, which again, I think as we're talking about global health in the future is really about capacity building and teaching. And our role should be education, as well as education and learning from the folks that we're there with. So there were several medical students who worked with us while we were there who served as interpreters, but we provided lectures and suturing skill, a suturing skill lab to them. And then we were also training local surgeons. So pictured here is Dr. Pastor, who was doing a colpoclysis that I was taking him through, and he's attended now a few of the missions. And so, he's basically been trained in some of these procedures, and hopefully is going to go back to his home country, Burundi, and do these procedures himself. So, that's our goal too, is to build capacity in countries so that we're not needed, right? So that would be really the ideal future goal. So I think I use this all as a framework to say I'm really excited about what we can do for our residents here and thinking about what U of M's global mission should look like. And there are several faculty here who I know are very interested in helping out with this, and we're really trying to think about what should our resident initiative look like. The U of M Global Health Equity, so there's a very strong global health school here at U of M, and they've done a lot of work really, again, talking about what is equity, how do we think about these processes, and how do we think about modern relationships. So I really like this framework. When we think about partnerships, it needs to be mutually beneficial. It should not just be what our needs are, but we need to understand the needs of our partners. We also need to make sure that we are agreeing upon what each person's role is and that we're setting our goals together. If you're doing research and publications, everyone should be authors and we should be equitable in how we're distributing authorship. And then we also want to look at what our outcomes are. I think that is such an important part of global health, is really thinking about outcomes and how do we measure outcomes, because it's very easy to do surgery and then not track what's happening. So we are working on a new resident rotation that will hopefully start next year. And some of the key parts that we want to include are cultural competency for our residents to really understand what it's like to go practice in another part of the world. A key component of this will also be having a pre-departure coursework to really think about some of these aspects of global health, and then coming back and having a debriefing as well, because really these experiences can be very impactful, and I think it's important to have time to actually debrief about what you've learned and what you've seen. Learning how to function with a diverse team, especially in places where maybe you don't speak the language, that can be really difficult, and so I think it's a very valuable skill. And then I really hope that we will foster some collaboration in research. I think that's something that we really can do and really advance the science. And then exposure to different pathologies and diagnostic techniques. So I have several close colleagues in Senegal, and the plan is hopefully to have a 2-week rotation that would encompass spending time at the main hospital in Dakar, Senegal, as well as in a rural clinic, so it gets some experiences kind of in both locations. And then there are several faculty in our department who are really excited and engaged to hopefully continue this work. So this is a really nice article that was done, again, through U of M, kind of, again, talking about global health and what should learners think about. So I put these 10 questions up here, again, just as food for thought if you're thinking about global health. So what are your motivations? Why do you want to do this? And what is your impact on the local setting? So when we go, we create a lot of impact. It disrupts the way that everything's going there. There's a whole lot of other factors that you bring in when you bring in a team. So thinking about that impact. How do you mitigate those disruptive effects, and make sure that you're not disrupting kind of the local flow in the system? Are you actually creating greater good? Are you actually creating sustainability? Are you prepared to approach things with cultural humility? There are a lot of situations that people encounter that you are maybe not prepared for, and really thinking about how to be humble and understanding of those situations, because people do things differently, right? How do you respond to ethical dilemmas? So there are a lot of different questions that will come up in how people approach care. And are you going to communicate bidirectionally with the people who are there? So, a lot of times mission trips can tend to be very kind of consuming of a health system when you arrive. So really thinking about what that impact actually is. Are the financial resources justified? So this is a kind of an important question I leave you all to think about, but it costs a lot of money to do these kind of trips, and is it justified to do that? And I think those are questions we need to ask. How are you going to provide feedback? And how are you going to reflect on this? So, what is your future in global health going to be? And how are we going to continue to sustain these equitable partnerships? So I kind of leave you with, I think the team is ultimately so important. And really for these to be successful, you have to have successful relationships and collaborations between yourself and the home institutions that you're working with. And they can't happen if you don't have those. And a lot of times I think successful global health initiatives happen because you have a local champion. And if they leave, sometimes those processes can really fall apart. So our goal is to kind of foster this collaboration. I think we have several great relationships that are forming. So I'm very excited about the future of this. And I hope that many of you in this audience will support us in continuing this work. So happy to take any questions.
Here we go. Do you want to try catching? No, you're not catching it? Okay.
That was a lovely talk. Thank you very much. Well, I had one question. So you had that form or that analysis they were supposed to go through to show the competency, and it was in English. What languages do you translate into the language of the?
Yeah, so the trainer that I did, we translated it into French and English so that it was so it could be used kind of throughout most of Africa, depending on which language was spoken. We haven't done local languages, but we've done French and English with the trainer.
What is the local language, and would it be important to translate it into the local language? Wouldn't that be the most?
You know, I talked with the surgeons there, and most of them felt that if we had French and English translations, that would be enough, because most of the medical personnel spoke one or the other. So.
Okay. As Dr. Cameron is coming up, she's going to give us essentially what's the 7th inning stretch. She's going to go over some ergonomics with us, particularly in the OR. And while she's coming up, I'm just going to say we're also reinvigorating the Michigan Urological Society. So if you're part of that, just look out for your email. If you don't get an email from that group, please let me know. We are having a reception at the North Central, which is purely social, and also a relaunch for the group. Dr. Stoffel is part of the group as well, and he's not here today, but we would both love to see you there.
Great, thanks, Mitty. So I'm speaking today on behalf of Dr. Kristen Krauser, who's the chair of the Wellness Committee, who had an unforeseeable conflict. She's actually giving a talk for another organization right now. But this is a handout that everyone has access to when you came in today. And it's laminated because many of our ORs require that paper be laminated to be able to be posted in the operating room, which is why we laminated it. And again, as surgeons, we know that we have a very physical job and we want to have a long career. And the only way you're going to have a long career is if you can preserve your physical functioning as best you can to be able to work as comfortably and as long as possible. And there are some handy tips on how to optimize your workspace. I think these are great habits that you should establish very early in your career to optimize your workspace from maximum efficiency, minimal pain, because you obviously work and think better if you're not in pain while you're working. But there are certain things called team stretches that can be done while scrubbed in the operating room. And again, you're not going to do these for very short cases, but in long cases, taking micro breaks actually will improve your efficiency because you take a small break, reset your mind, and then proceed with your surgical case. So I'll invite everyone to stand if you choose. This can also be done seated, but I would actually just invite everyone to stand to do this if you so choose. This takes 60 seconds, so this is not a big time commitment when you're doing cases. And so I'll ask everyone, because you are scrubbed during this and you're not going to be breaking scrubs. So clench your hands, stand tall, inhale, and exhale. I want you to shrug your shoulders and then pinch your shoulders back as hard as you can. Oh, I heard a huge crack when I did that. And then bring your shoulders down. Push your hands away, following with your shoulders, and then bring your shoulder blades back, pinch them together. Repeat with your hands pushing out. Oh, another crack. That was fantastic. I want you to look up at the ceiling. Inhale. Curve. And inhale. I want you to stand with one foot in front of the other. Whichever foot is facing forward, look in that direction. Bring your torso. And then on the way back, do a side lean in the opposite direction. Switch feet. Again, lead with your head and then with your shoulders. That feels fantastic. And then lead to the side. Can you tell I really enjoy yoga? And then I want you to clench your glutes and lean back. Clench your glutes and then do a crunch where you're standing. Stand tall. Inhale, exhale. Go have some cookies. Thanks, everyone.
With great pleasure, I'm going to reintroduce Dr. Gupta, who is now going to talk about an update on our residency program. She is our new program director. Let's welcome Dr. Gupta.
Okay, so sorry, you'll have to hear me talk again, but so as Dr. Go said, I had the great pleasure of taking over the residency from Dr. Kate Kraft in July, and I'm really excited to be the new program director. And just want to update you all a little bit on what our residency looks like today, some of the projects and initiatives that we have going on, and some future directions that we're kind of excited about. So our mission as a residency is to train clinically well-rounded urologists who are uniquely poised and motivated to become the next generation of innovators and leaders in the field of urology. And when we say this, we don't just mean academic leaders. As many of you in the room know, we hope to train people who will be leaders in our communities, leaders in patient care, and really providing excellent patient care in whatever facet of their career that they choose. And we hope to support and develop that. So our mission is a tripartite mission. So we have clinical care, research, and education. And I'm going to talk about each of these areas and how they're applying to our residency. So this is our leadership team. So Dr. Palapattu and Dr. Hafez, our chair and associate chair for education. And then I'm joined by two amazing associate program directors, both who are not here right now because I think they're both working on call, but Dr. Barbolio-Romo and Dr. Blair, who are both our associate program directors and have each been taking on a specific role. Dr. Barbolio is helping with our sub-interns clerkship and medical clerkship, as well as working on open surgical skills. And Dr. Blair has really taken charge of a couple aspects of our curriculum, robotic surgery, and some special events, which we'll talk about some more. And we have our two new vice chairs, Dr. Cameron and Dr. Montgomery. So we always say it takes a village, and for those of you who train here know that it is really important to have engaged faculty, and we have over 40 clinical faculty, but I think what we're really fortunate here is that our faculty are engaged in education, and the people you see here are serving in a number of facets for the residency. We have core educational faculty who are in charge of each of our rotations and help provide our residents with feedback and expectations. We have very strong fellowship programs here, which do not really, I think, if anything, enhance our residents' experience because they have a chance to work with additional learners. And it also continues to help develop our surgical cases and complexity that residents are exposed to. And then we have a program evaluation committee that meets regularly to really look at the residency and make sure that we're continually improving what we're doing. So these are our fabulous residents, our PGY 1 through 5 classes, and we have expanded our program where we take 5 residents every other year to have a research track, which we'll talk about. So I also want to highlight Joel Barron. So University of Michigan was chosen as the first physician scientist residency training awards site. So Joel is doing an additional 3 years of research, so it's a total of 8 years in the program. And this was a great honor to be chosen for this and really speaks to the research that's happening here at University of Michigan. So we have a number of clinical sites, and as we have expanded our clinical footprint and moved outside of Ann Arbor, it's offered opportunities for our residents to get to explore different sites and have exposure to different pathologies and different populations. So of course we have our flagship hospital, the University Hospital, and the Mott Children's Hospital, where our residents spent a significant amount of time. And then we have the VA, which is really, as many of you probably remember, an excellent experience for our residents to really have the opportunity to run a service and be in charge of that location, take care of the clinic, take care of the patients and the OR, and kind of have that full experience of being the practitioner there. And then we have a favorite rotation for our 4th-year residents, which is at St. Joseph Mercy Hospital. And this is a community practice. We have some of our faculty from there who are here today. And our residents get a chance to experience more of a community practice during their 4th year. And then we have St. Joseph Mercy Chelsea Hospital, where many of us have actually started operating, including myself. And that's an opportunity for our chief residents to get to go operate at Chelsea Hospital and again experience kind of a different type of setting, as well as a different population of patients. So we'll talk a little bit about our curriculum. So in the PGY 1 year, our residents spend 7 months in general surgery and 5 months in urology, which is really excellent. I think as training has evolved, we found that it's really effective for our residents to spend more time with us during their first year and begin to start developing their endoscopic skills and getting used to taking care of urology patients on the floor. During the PGY 2-year, they spend time in endourology. They do consults on the floor. They spend time on our oncology service, again, starting to assist in big open cases as well as bedsiding for robotic cases. They spend time at the VA. And then this year we included a rotation in neuropelvic medicine and reconstruction, so trying to get our residents early exposure to this area of urology. During the PGY 3-year, we spent a little more time in some of our different subspecialties, so endourology and general urology, and they spend time doing all of that work. We have a clinic kind of float month. So actually, again, I'd like to highlight that as a residency, we've really tried to listen to our residents' needs. And last year it was brought up that they didn't spend enough time in clinic. So we added a clinic rotation during the 3rd year to allow more exposure to different aspects of clinical medicine. And then they have a night flow rotation, peds, and the VA again. During the PGY 4-year, we have time in our lap endourology rotation where our residents get to do a lot of upper tract reconstruction. They also do some night float. We have elective time built into this year, and that's a time for our residents to get to explore specific interests that they may have. So we've had residents rotate in interventional radiology, urogynecology, colorectal surgery, radiation oncology, and this is hopefully where our international elective would also fit in the future. And then again, I mentioned pediatrics and St. Joe's. And then our chief year remains a very operatively heavy year for our chief residents. They spend time, again, with the neurourology reconstructive group where they get to do a lot of open surgery, oncology, the VA, and then at Chelsea as well. So we mentioned the 6-year track, and so we've been matching residents now into a 6-year research track. And the way that works is that between their 3rd and 4th year, they spend a year doing research and then return back to complete the rest of their residency. And really the opportunities are pretty endless here at Michigan to do research in basic science, translational science, health services research, and surgical education. And our 2 current residents that are on this track are Brandy Branch and Hannah Glick. And Brandy is going to be starting her research year after this year and is looking at doing work in the neurourology reconstructive surgery area. So we're really excited to see what she does over the next year. So for our residents, I think mentorship is a very important part of residency, and all of our residents are assigned a mentor when they begin their residency who is going to help guide them throughout their 5 years. And what I think is really amazing about this place is that we have so many faculty that most of our residents have their assigned mentor, but have other people that they turn to for mentorship, for research mentorship, clinical mentorship, decisions about fellowship. There are just so many people here and so many resources that I would say most residents have more than one person that they turn to for advice and sponsorship. So we, try to make clinical work fun. We know clinical work is things like consults can be a little bit painful. And Dr. Wan on our pediatric side really took the idea of consults and made it kind of a fun competition for the residents. So we highlight the Tour de Consult that he gives us data about every quarter. And this is a competition for the residents to kind of keep track of the consults that they're seeing. They divide up into teams at the beginning of the year, and we track the consults. So before this program started, many consults weren't recorded. And after Dr. Wan instituted this program, the number of consults that were being recorded certainly went up significantly. And we've been able to create a database to kind of see the types of consults that are seen. But I think sort of the best part of this is at the end of the year, Dr. Wan does this great awards ceremony and recognizes all the residents by the number of consults that they've seen, which team did the best. There's sort of historical data. And then there's usually a prize. Someone wins an iPad. So it's, just kind of a fun way to make what can be a painful type of service a little bit more fun. So next we'll kind of talk about our curriculum. So we have a very robust educational curriculum here. It includes grand rounds, several faculty lectures. We have resident conferences, the point-counterpoint debates, which I think is one of my favorite parts of the curriculum. The residents usually choose a topic at grand rounds, debate it. So for example, if it was in prolapse, it might be, should you sling a patient or not sling a patient at the time of prolapse surgery? And it's really fun to hear the 2 point of views being discussed. We have mock oral boards, surgical skills, and robotic curriculum, which we'll talk about in a little more detail. So this is a picture of some of the training labs. This is Dr. Malaib, and he usually does a male reconstructive lab every year during which time the residents have the opportunity to do implantable penile prosthesis, artificial urinary sphincters, kind of look at the anatomy. So this is always a really favorite experience of our residents. And then we also have additional lab time where residents can work on endoscopic skills. And then this is something that's new that Dr. Blair has really instituted over the last couple of years. And I think this is really, I would say, kind of at the forefront of education for robotic surgery. So this is an opportunity for our third-year residents to get to do a pig lab where we have actually live anesthetized pigs. And we bring the Da Vinci robot in, and they're able to do a full case from start to finish. So a nephrectomy, ureteral reimplant, sort of a choice of the procedure, and it's supervised by one of the faculty, and it's a one-on-one experience, one faculty, one resident, kind of start to finish through a surgery. And I think this has been a really great experience because it actually gives you the chance to kind of really see what that feels like, and all of the troubleshooting things that happen, you know, how do you need to position the patient? How do you put the ports in? How do you direct your bedside assistant? So it's been a great experience for our residents. In addition, Dr. Blair also started the robotic passport. And so, you know, again, as we're thinking about the future of how do we develop competency in robotic surgery, the question is always, well, when is someone ready to get on the console? And so we've tried to create a little bit more of a curriculum which expects our residents to complete the simulation exercises that are provided with the robotic simulator. And then we want all of our residents to provide evidence of having bedsided for the kind of the key procedures, prostatectomy, nephrectomy, and cystectomy. And then once all of that's completed, you know, your passport is signed off on, and that's your visa or your ticket to be able to sit on the console. And that's a way for us to help our residents be able to show different faculty that they've achieved the basic competencies and are ready to be on the console. And with the number of faculty that we have, this is kind of a nice standardized way that we can ensure that people are ready to go when it's time. And this is something we hope to do by the end of the PGY2 year. Another part of the ACGME competencies for residency is quality improvement. And a number of us have been, so Dr. Hutchmuth and Dr. Krauser have really been the champions of our quality improvement curriculum. And like many quality improvement initiatives, this curriculum has undergone several quality improvement cycles of its own as we have tried to figure out what is really the optimal way to try to incorporate this into our training. And so our residents have participated in root cause analyses. They've really tried to look at issues that affect their day-to-day existence. You know, is there a problem with your consult service? Is there a problem with how you're receiving pages? Where are opportunities for us to improve the process? And then for the residents to kind of engage in a project, assessing that and trying to come up with a solution. And typically our residents present their solutions and their problem in a grand rounds at the end of the year. The other component of our curriculum that Dr. Kraft has really helped start in the last couple of years is the Matula Leadership Program. So again, we felt like it was important for our residents to not only be getting didactic training in the basics of urology, but also to be developing these other skills, including leadership. So we've added this as part of our core curriculum to try to develop some leadership skills and talk about leadership development. And then another kind of part, I think, as we, again, are evolving and what is education looking like in the future is how do we give good feedback and how do we assess competency in the OR? And so, I think a common thing that most programs face is, are we giving enough feedback? Are we telling residents if they're doing well? And so Simple was sort of born of that. This is an app that allows for feedback to happen, and it's being used by several programs around the country. And our program has really been a champion of using this program. It's an opportunity for residents to get real-time feedback on certain points in the case. So they submit a request to the faculty, and the faculty assesses them on specific areas. And then they also can assess the faculty on their teaching. So we think this is a really great method to help start providing more of that just-in-time feedback. So now we'll switch gears and talk about our next part of our mission, which is research. And we have a very robust research curriculum. So this is a picture of some of us at AUA this year, but our residents are very productive in their research. And if they are able to present at a conference, then as a department, we sponsor residents to present at conferences, up to 3 during their residency that are sponsored by our department. So as part of the research curriculum, our residents we've instituted kind of a new protected time model. So as most of us know, if you're trying to do a research project, when you're given a research block for a month, a lot of times it's hard to actually get something done in that month. The IRB is not ready or something happens. And so instead what we've done is we've added a half day of protected time per week that's really at the discretion of the service requirements, but allows for our residents to have more longitudinal time to work on projects. So time to meet with the statistician or meet with your research team and help move move your projects along rather than kind of one large block of time. We have didactics that are built in, statistical support, and we'll talk a little bit about our statistical support specifically. And then in the spring, we have a resident research day where all of our residents are expected to present a project that they're working on. It doesn't have to be completed, but something that they're working on and can demonstrate kind of some progress in. And then I mentioned conference travel earlier, but this is our research team. So Dr. Clemens is the Associate Chair for Research, and then Dr. Aruna Sarma is our Chief of the Health Services Research Group and has really helped kind of champion our research didactics curriculum. And I think one of the great resources we have for our residents is Stephanie. She is our biostatistician who is available to help with resident research projects, which I think is a really unique resource and is one that has been really, really welcomed by the residents to have someone dedicated to help move their projects forward. And then we mentioned music. You've heard about music before, but this has been an excellent opportunity for our residents to get involved in research projects that allow for collaboration with other urologists throughout the state of Michigan. And several of our residents have published many papers and projects through music. So this has been a really great collaborative and opportunity. So we'll talk a little bit about wellness too. So, we all know that as we look at surgeons, certainly surgeons are experiencing more burnout, and so are our residents. And so having wellness be an important part of our residency has been key. And this really comprises looking at a few different areas: physical health, the social connections, mental health, humanitarianism, and work-life integration. And so we've had a few different options that we've kind of tried to incorporate into the residency. The University of Michigan GME office has provided Headspace, which is a mindfulness app, but they also have several other resources that are provided to our residents. The picture on the left shows Mahir, one of our residents, at a community event. So we actually have been involved in several community events looking at outreach for helping expose students to healthcare fields early on. And so this is Mahir doing an event in the big house showing people endoscopy. So that was a kind of fun event to engage with the community. And then there's some other pictures here of fitness. Dr. Palapattu always takes the residents to Blue Lion Fitness to work out every year, and we usually do some other fitness activities throughout the year. So again, some things kind of really aimed at wellness. And then this is a new initiative that we started this last year. So again, Dr. Blair, this was something that we wanted to do, which was a resident retreat. We've never had one before. And the idea behind the resident retreat was to bring our residents together and give them some time to really get to know each other a little bit more in a different way, do some team building. We also address certain service issues. So one of the deliverables was to talk about issues that were affecting service and the residency and talk about solutions for that. And we also had a coach who talks about leadership development and skills. So these are our residents at the retreat this past April. And these were some of the quotes from our resident retreat, but I think it was very well received. And, the feedback that we got was that people wish we had done something like this before, and that it was an opportunity to really get to know your team members in a different way than we have in the past. And so again, as we talk about wellness and team building, this is something we've really been attuned to and are excited to continue to support. So from a DEI perspective, so again, kind of talking about special initiatives, Dr. Go, who you all have seen many times through today, is our chair of DEI work and has really helped spearhead several initiatives within our department, which I think are really innovative and speak to, again, the development of our workforce. So we have a couple different ones. So one is Uroversity, and this was actually the brainchild of Dr. Christian Black, who's one of our residents here. And he started this idea as a medical student. And the thought was, again, that we want to look at how do we diversify our workforce. And so this is a program aimed at underrepresented groups within University of Michigan. And we try to recruit students early in their M1 year. And then it's a longitudinal 4-year program where the students are provided early exposure to urology, shadowing opportunities for research, and then as they get further along, if they are choosing urology as their career, we plan to provide them additional support in terms of preparing for clerkships, learning surgical skills, helping again with developing their CV and their research, and connecting them with opportunities. So we currently have 2 cohorts where we have M2s and M1s that are going through this program right now, and we'll continue to track and see how our progress is. The next initiative that we're also very proud of is the Michigan Urology Academy. So Dr. Go, Dr. Palapattu, and Dr. Salami really spearheaded this initiative. And it was actually started during COVID. So the initial idea had been to have students here from around the country kind of being provided exposure to urology. And so this is students that either have traditionally been underrepresented in urology or who don't have a home urology program. And so this year was the first year we were actually able to bring students in person. So we had 12 students here in person, and we had an additional 92 total that attended virtually. So really it was a great turnout. And during the Urology Academy, students were given exposure again to several different talks about mentorship, sponsorship, how to deal with microaggressions in the workplace, how to be a successful urology applicant, some of the tips and tricks. And then we included those as well in the virtual component of the Urology Academy. And then, as a reminder, University of Michigan is an excellent place to train. And I think we benefit a lot from the resources of the university. So we know this is, a top-notch university. And because of this, our residents have the ability to collaborate with people across many different departments. And so I always like to remind everyone that if there's something you're interested in, there's probably somebody here who's an expert in that. And that's something I think our residents really benefit from. And where do our graduates go? So many of you who are here in the room, we know that we have University of Michigan graduates that are all over the country and around the world. And I think the Nesbit Society and, of course, our alumni really speak mountains to the loyalty people feel to this program. And I think it's because of the culture that's here and the support that we provide our trainees, but the support we hope you will continue to provide each other as you go on into your careers. So this last, rankings are what they are, but the University of Michigan Hospital was number 9 this past year, and then our residency was ranked number 3 in Doximity, so we're very proud of that, and we hope to continue that tradition of being a top residency in the country. So I want to now just congratulate our chiefs, and I think this is going too quickly. Let me go back. I don't know if I can go back. Can't go back. Okay, well, our chiefs all matched in excellent fellowships this year. So it went too quickly. But we are very proud of all of our chiefs and where they're going. And these are some pictures of all our residents having a good time together. We really do think we have the best residents in the country. And I think what makes this place so special is the people that are here and the fact that we really do support each other and everyone really does care about providing the best patient care and being leaders in our field. So the things that our leadership team is excited about kind of moving forward, we certainly are, now that we've expanded our residency a little bit, we're hoping to continue to develop our elective opportunities, so more within the university, but as well as global health programs. I think the future of surgical education is also starting to think about competency-based education and what does that look like, and that's something that I know Dr. Kraft had already started to explore, but we hope to continue to explore in the years coming forward and really to hope to be the thought leaders. And then continuing to work on how we develop surgical skills and looking at innovative ways of developing those and assessing them. So thank you all for your support. For everyone in the room, we hope you'll continue to support the residency as well as some of our new initiatives and help us kind of remain at the front. Thank you. Go Blue.
All right, so we're here at the end of the program. Thank you, Dr. Gupta. Before I get started, I just also want to reiterate my thanks to all of you for being here today and provide an opportunity for reflection about how lucky are we to be a part of this really amazing program and legacy. It always reminds me this program, our Nesbit AUA event, interacting with our alumni, residents, as well as former faculty, of the extraordinarily strong job, an amazing job that both Drs. Bloom and Dr. Montie did for us. And we are the direct beneficiaries of their hard work through tough times, as many of you know, in the late 90s, as was alluded to earlier from Caleb Nelson. Really words cannot express the amount of effort, both behind the scenes as well as outward that Dr. Montie did for all of us. And then Dr. Bloom continued to amplify the impact of this program. So I'm extraordinarily grateful to both David and Jim, and also extraordinarily grateful to all of you. You are the Nesbit Society, you are the University of Michigan, and to all of our trainees here today, our current trainees. I wonder how it makes you feel to think If you look back at all the people who are here today or visiting, you see all the extraordinary impact that our former residents have done. You see that the new students who are coming up who will come after you, and recognize the important fabric in which you live in, and that you'll always be connected to the Nesbit Society wherever you go. And it's really an extraordinary group of people. So you should be proud. We're extraordinarily proud of you. I'm talking about our current residents. I know it's hard to believe, but I am. And it's really, really an extraordinary event. So with that, I'm going to move forward here with give the state of the department. I can summarize it quickly. State of the department is strong. All right, see you later. No. I thought I'd really quickly recap mostly our vision, mission, and values. I thought Khurshid did a really good job of today, really tying the end of his talk into this. But for those of you who haven't heard it before, the vision of our department is really simple. It's to a world free of suffering from urologic disease forever. The mission, as Khurshid said, again, really simple. It's to help people, patients, peers, the community, and the world. And that can be done in a number of different ways. Our core values are things like honesty, integrity, empathy, compassion, hard work, collegiality, authenticity, accountability. Of course, underscoring all of this is teamwork. These are the kinds of things we look for in prospective trainees, prospective faculty, and these are the sorts of things I think all of you should expect from me and our other faculty to embody every day. And I know we don't do that all the time. Where are we now? Well, last year we saw approximately 81,000 discrete patients, over 19,000 new patients, and almost 10,000 operative cases. We see patients all over the state of Michigan, and many of these red dots are accounted for by Dr. John Park, who goes around the state to see pediatric patients who need help. He goes to Battle Creek, he goes to Marquette. Many of our faculty here go to Midland. I'm extraordinarily grateful to all of our faculty who take on the mantle of helping and to serve others, who are really live up to that mission of helping people. And even though it's not convenient to them and their families, they go out and serve others who need them. These are all of the other sites that we currently see patients. And one thing I wanted to do highlight is Ypsilanti. Ypsilanti Health Center is a new primary care multi-specialty clinic that's going to be put up, that will be finished in 2025-ish. It's mostly primary care. The second wave will involve surgical subspecialties like urology. This is in the community of Ypsilanti, which is quite a bit different socioeconomic and demographic makeup than Ann Arbor. But many patients in Ypsilanti choose not to come to the University of Michigan. This clinic is going to be extraordinarily important for Michigan medicine, I will dare say for the urology. And I intend to be the first faculty member who sees patients out there. And I assume that my anticipation and my goal is that Ypsilanti Health Center will be a clinic where faculty go, not where trainees go first. And when faculty go there, it will be our most seasoned faculty. It will not be our most junior faculty. A very important thing that we need to do as a healthcare system that we have not done well, Michigan medicine has not done well, our department has not done well, is community outreach. It is to develop relationships with patients and populations who need our help, but don't see themselves in us. And we plan to change that, I hope, in the next 3 to 5 years. Another big thing that's happening that many of you have driven by the campus, it's hard not to notice. It's the Dan and Betty Kahn Pavilion. It's that big, large hospital building that's across from the observatory right next to the CVC. It will be open in the fall of 2025, approximately a 12-story building, 20 new operating rooms, over 250 new beds. It will allow us to backfill and remodel UH Hospital to convert all of the remainder of the dual occupancy rooms that we have there into single occupancy rooms. It really will be a state-of-the-art hospital. Again, all of the rooms in this new hospital will be able to be converted into an ICU. All beds will be able to convert it into an ICU if, in fact, they need be. While urology will not have a strong presence in this building, the remodeling and movement of services in UH to this building will create new opportunities for us in UH. So I don't know how we're going to see consults in this place. Honestly, I do not know. Just the physical space to cover for our residents / faculty will be a challenge. Maybe Dr. Keel will help us with this. I don't know. Put on your running shoes, kid. But it's, I don't know. But we're gonna have to figure this out. And the consults, while simple, will be extraordinarily complex because we'll have very, very complicated patients who might have simple urologic problems, but as you all know, the consults will not be simple. So to be decided and to be figured out how we're going to address this, but coming soon to a theater near you is how we're going to manage all this stuff. Currently, our faculty is comprised of 54 extraordinary individuals, 49 full clinical and clinical faculty, and 5 are research only. You can see here how our department breaks down currently. 2 vice chairs. Since we met last, we have reorganized the structure of the department somewhat. We have 2 vice chairs now. Vice chair of academic affairs is Dr. Ann Cameron. Vice chair of clinical affairs is Dr. Jeff Montgomery, and both of whom have discrete portfolios and are doing a great job supporting me to support all our faculty, staff, and our trainees. You can see all of our different professor levels there, our various associate chairs, and of course we have a UMG leadership role, and Jim Dupree as our ACCC also. This is our resident team, as Dr. Gupta said, really a great group. And as the slides didn't allow you to talk about them, I'll talk about them now. Anna Ferris, so all 4 of our chief residents did very well in their fellowship match, all of whom got their first choice of where they wanted to go. Anna Ferris will be doing a reconstructive GERS fellowship at UCSF. Mahar Maroof will be going to Johns Hopkins to be reunited with Arvin George to do endourology. Kathy Nam will be doing infertility andrology fellowship at Northwestern. And of course, Alex Zhu will be doing SUO fellowship at the University of Washington. Extraordinarily proud of all 4 of you. Really extraordinary job during your residency. And we wish you the very best. Of course, you're not done with training yet, by the way. And these are our other residents, and you'll see down there is PGY 5, Joel Behrens, and as Priyanka mentioned, he's sort of stuck in this infinite loop, but he'll still be on the slides probably next year and the year, a couple of years after that. But he's doing really a great job in the lab, and I'm hopeful that next year he'll be able to present a brief snippet of what he's been doing in the lab with Dr. Setu Pichaya, really doing some foundational work, and I believe they're actually in the process of submitting some of the work to Cell. So it's really an amazing research work that Joel has been able to do. We also have a large group of fellows. We have 6 oncology fellows, almost 1 for every organ. We also have endourology and, of course, NPR, FPMRS, and a number of other research fellows. So we have also a very large fellowship group. As was mentioned earlier by Dr. Nakata, it's a very extraordinary report, and I also agree that for a department to have influence and impact within the healthcare system, the faculty have to be engaged in the medical school and the hospital. If you are not, you'll never have a seat at the table. It'll always be us versus them. You'll never have an opportunity to influence things in the way that you think that might be beneficial to you and your department. This is the list of all of our faculty who are integrated in some meaningful way into our health system, from David Miller, who, as you all know, is the president of our healthcare system, all the way on down. And it's almost invariably the case where you see when decisions are being made at Michigan Medicine, almost always there's a urologist at the seat at the table. And that doesn't go unnoticed by the health system leadership. I've been told many times that there's too many urologists running this hospital. And my retort to them, usually other chairs, is, well, it's called professional development. Heard of it? Why don't you try that with your faculty instead of, trying to, being a urologist cannot be a disqualifying factor. The fact is that we intentionally cultivate individuals to pursue these other areas. Similarly, I'd like to consider ourselves as a national talent donor for faculty around the country. As many of you know, over the past year, 5 of our faculty have moved on to really exceptional positions around the country. John Hollingsworth took on a very senior leadership role in Chicago as a leader of acute care quality at the North Shore Health System. Alone Weiser, we're lucky to have Alone here today. Alone is a senior vice president and CMO of Mount Sinai Medical Center in Miami, Florida. Ted Scaleris, Director of Implementation Science at the University of Chicago for the Department of Surgery, for the entire Department of Surgery. And of course, Arvin George now, who's a Director of Prostate Cancer Care and Prostate Cancer Programs at Johns Hopkins. You can imagine that's no small title and a very large thing to live up to. And last but certainly not least is our good friend Brent Hollenbeck, who wishes he could be here today. He will be at the tailgate tomorrow. But Brent, as all of you know, is now the chair at Mass General Hospital. We're extraordinarily proud of all of them, and we are certainly their biggest cheerleaders. We're very fortunate to be supported by a very generous group of alumni and friends. We have a total of 14 endowed chairs, the newest of which is from Ms. Carolyn McQuiggan, who's over here today, who it was nice of you to visit us with us today, Carolyn. And she'll also be with us tonight, and you'll see all the different chairs here. And we have 4 more additional chairs in progress, and I'm proud to say one of them will be for Dr. Carol Bennett, who's also here today. Dr. Bennett was, as was mentioned earlier today, was the very first female urology resident at the University of Michigan. She was the first African-American female to be board certified by the American Board of Urology. She was on the faculty here for many years before she went to California. And I'm also proud to say I'm a student of hers. I was trained by Carol when I was a resident at UCLA. So it's really a distinctive honor for us to be able to honor you, Carol, and your extraordinary legacy, not only for the University of Michigan, but also for urology. And very soon we'll begin the fundraising campaign for a chair in Dr. Bennett's name. So again, Dr. Carol, thank you for joining us today. Well, as I'm wont to say, rankings are always flawed, but sometimes we like them depending on how they turn out. But anyway, at least for the NIH ranking, we're still remain number one. The Doximity popularity contest that it is, as Priyanka pointed out, we're number 3. The U.S. News World Report this year, we were actually 19. You have to add a 1 in front of the 9. But as you know, the methodologies are all what they are, and it is what it is. So where are we going? And I'd say there's 3 areas where the department is moving the next 3 years or so. One is clinical expansion. I did already mention the pavilion. We're going to be expanding our clinical presence at Chelsea, which is approximately 20 minutes away from here in Ann Arbor, in the western side of town. We've already hired another faculty member to join that group full-time in the summer. And I fully expect that footprint to grow even more. And as that grows more, our trainees will be spending more time there, and also will be more opportunities for clinical research. I did mention Ypsi as well, Ypsilanti. And on the west side of the state, not only in Chelsea, but even farther west to Muskegon and West Shore Urology, there are communities from Ann Arbor essentially to the lake that need help. There's pockets here and there of urology deserts, of healthcare deserts, and I feel it's our responsibility to be able to provide care to those patients who need it most, and we will continue to find ways to help those patients. As was mentioned earlier, we've certainly done, I believe, a reasonably good job of reinvestment and discovery. Both myself and Dr. Hollenbeck for the past 4 years or so really spent a lot of time about trying to think about how can we ignite inspiration amongst our trainees. And from that, we came up with this incubator program where we fund research ideas from our residents, about $10,000 each, sometimes $20,000. There's no limit on a number of them we can fund, all through generous philanthropic support. And we've had some amazing studies proposed, from clinical trials to translational studies. It's really been gratifying, and I think it's made me very, very proud of all of you guys. Further, we've also thought about how can we help catalyze our junior faculty to take their research from really the burgeoning stage, or maybe the inchoate stage, but move it and mature it. And we created this Catalyst program where we provide faculty with $50,000 to $100,000 of no strings attached money to help them push them over the finish line. I'm proud to say of 5 of those awards, 3 have already resulted in R01s by our urology faculty. So that's been extraordinarily successful thus far as well. And as I mentioned earlier, our community outreach, Ypsi will be the new focus, and our team continues to supply urologic care at the Federally Qualified Health Center in Flint, Michigan. And almost always, there's maybe 3 days of the week or so, still there's a urologist in clinic at Flint from our department. So I think, again, a common refrain we have is our biggest strength is our culture, and all of you, I hope, have felt it today. Our biggest resources are people, and those are the people sitting to the left and to the right of you. I want to thank you all again for your attention today, for your spending your precious time with us. I hope you will all have an opportunity to come to the dinner. The residents have a particular surprise in store for many of you at the end of the dinner, I think. And I hope that many of you can also come for our tailgate and also the football game tomorrow. Thank you all again. Go Blue.